Good evening to everyone. It's a pleasure for me to be here again. My name is Juan Blanco, and on behalf of SEPA, I would like to introduce the next session. But before, allow me to thank to Camlog, Horizons, BioHorizons, that they always are supporting SEPA and SEPA Foundation. So thank you very much for allowing us to do this corporate forum. I would like to send a message of health to everyone online and also to the people that here is on site. This session will be about the current concepts about L-PRF. It will be an evidence-based approach, and I would like to introduce our moderator, Professor Gil Alcoforado, from the university. He's current rector from the University of Egas Moniz. So, Gil, thank you for being here and for being our moderator for this, I hope, exciting session. Thank you.
Thank you, Juan. Thank you very much. I would like to thank SEPA Foundation for the invitation, and BioHorizons Camlog, who's sponsoring this session. This session will have very nice group of experts, and I'm going to introduce them in a couple of minutes. Before that, I would like just to show you a couple of cases that would give the motto of this session. And I would start with a regeneration of a non-contained defect, this one, where I've decided to extract this tooth, place L-PRF membranes, and I was able to, within 4 months, to achieve this result. I mess up with the buttons here. Here is the result before and after. Another very nice case with management of dental infections when they have a sinus involvement. You can see that in this case we have some of the roots of this molar protruding through the sinus and the sinusitis in this area. So we decided to extract the tooth, place L-PRF plugs, and very soon, 4 months later, we got this result. From here, we got to here, where the bone regenerated, but also, what is probably even more important, the sinusitis was completely resolved. Well, the L-PRF can be used also in other, extraorally, of course, and I would like to show you this case, which I treated a friend of mine, diabetic, that have lost already the toes of this foot, and because of this huge, really, this defect that was very deep, they were starting thinking this hasn't healed for several months. Actually more than a year, and they were starting thinking that probably amputation of the foot would be the solution. On the other foot, you can also see that there are some defects that are smaller, but also pretty deep. So in this case, we decided to try to apply the L-PRF treatment. So we did several applications. First of all, of course, we tried to clean the area just to make sure that the wound would bleed, and then make applications of L-PRF membranes, and also some injection of L-PRF exudate on the borders of the wound. We did this 8 times with 1 week interval, and I must say that I was very scared to do this, but thanks to the help of Professor Nelson Pinto, he kind of instructed me what to do, and I followed exactly the procedure that he told me, because he told me that those type of deep wounds would not be easy to solve, but especially because there is also the pressure of the foot. But this is the result we had on the left foot. The 2 wounds were completely healed, and also on the other foot, which was probably more problematic, we were able to close completely the wound. This was those pictures are from May of last year, and 1 year later they stay closed and stable. So this is very nice, but the fact is that these are just very nice cases. If there is no research behind, they're just nice cases, nothing else. And we are extremely lucky today that put the science that was probably lacking to this type of technique into the picture. And we have some of the most well-trained and experts on this matter to give you those evidence-based science. And we are going to start with Lidia Hermida, then Marc Quirynen, Nelson Pinto, who's going to present directly from Santiago de Chile, Juan Blanco, Marc Quirynen, that will speak several times on different subjects. So let's start with the first speaker. I would ask Dr. Lidia Hermida to come to the stage, please. And she's going to speak about biological rationale of the L-PRF. Why does it work? In 2015 as a biochemist at University of Murcia. She also studied, went through a master in biological research at University of La Coruña. Currently, she's finishing her PhD here at University of Santiago de Compostela in the group of platelet proteomics, directed by Professor Ángel Garcia. Her research is focused on platelets used in the transfusion field, and platelets concentrates apply in our field, in dentistry, due to their regeneration properties. Mm-hmm. During her PhD, she did a short stay in the lab of Professor Janne Roseland at University of Oslo, and she has published 3 papers as first author and 7 as collaborator. Dr. Lidia Hermida, please, the floor is yours, and thank you very much for coming here.
Thank you very much. Hello, everyone. My name is Lidia Hermida-Nogueira, and first I would like to thank Juan for inviting me to be here today. And as Jill says, my talk is about biological rationale of the L-PRF and why does it work. So first of all, we should say what L-PRF means. L-PRF, it's leukocytes. It means leukocyte platelet-rich fibrin, and there is a platelet concentrate. There are different types of platelets concentrate, but in the last classification done by Juan in 2014, they classify attending to 2 parameters: the density of fibrin and also the content of leukocytes. Attending to the density of fibrin, we could have low fibrin density or high fibrin density, and both of them could have leukocytes or not. In order to obtain the low fibrin density, there could be applied open system that in this case they obtain this platelet concentrate in liquid form that finally could be activated outside with thrombin or calcium, and finally we obtain this product in gel. But it has a low fibrin density. However, they could apply a closed system, but finally we obtain these products, but this one have high density fibrin. In this case, we have L-PRF. all these concentrates are applied in different clinical scenarios. For example, the high fibrin density are used more in dermatology and dentistry, and the low fibrin density are more applied in ophthalmology, sport medicine, and also to the treatment of some diseases as arthritis, due to its easy to handle. But L-PRF is the platelet concentrate most used in the dentistry field. The system is approved by FDA and also EMA, and it's standardized, so independently where you apply this system, you will obtain the same platelet concentrate. Here we have some transmission electron microscopy when we could see, how it composed this L-PRF, and we see that there is fibers of high fibrin density and also cells here that when you see in this amplification, we can see that there is platelets and also leukocyte content. In this case, we can see also that there is a very high content of platelet and also leukocytes, but these platelets sometimes are from aggregation. These concentrate, of course, they have platelets and leukocytes, as I say, and release many proteins. However, normally the authors only check growth factors because they are implicated in different effects depending on the cell types. For example, EGF, that it participates in fibroblastic migration and proliferation, FGF, that it has a role in chemotaxis of mesenchymal stem cells, osteoblastic cells, chondrocyte, and fibroblasts. Also, EGF1, that also promotes osteoblast proliferation and differentiation. PDGF, that is the growth factor most released by platelets and have an effect on collagen system and proliferation of fibroblasts. TGF alpha and beta, that promotes collagen system also, and fibroblast proliferation and migration, and VEGF, that stimulates epithelial migration and proliferation. So different authors have measured many of these growth factors in their platelet concentrate. In this case, in this study, they compare different platelet concentrates. They evaluate these growth factors and more, and they also measure the kinetics. In this one, they also evaluate only L-PRF block, but also its component. They evaluated also another growth factors, and of course, they measure, of course, their kinetics. In this case, they evaluated also two different again types, measure all these growth factors, and also their kinetics. However, platelets and leukocytes, if they are present, they are not only release growth factors, and there are many other proteins that release that we are not checking. Some groups, they want to identify these proteins, and they did it applying different proteomic approaches, but variability between proteomic approaches and platelet concentrate use, it makes it difficult to get a conclusion. Moreover, they then don't apply specific techniques that can permit eliminate majority plasma proteins, such as albumin and immunoglobulin. So finally, it's difficult to identify the proteins that finally are here, the 4% that there are masked. So for that, we started to work with Juan Blanco, and we want to identify the whole proteins released by these L-PRF membranes, and we have two objectives. The first one, it was this, identify these proteins, and also the differences depending on the incubation time. So in order to identify these proteins, we follow this methodology. At the beginning, we obtain the membranes, and we put it on a plate, and we culture over the time. At the beginning, we perform some washes in order to eliminate these majority proteins, and after that, we culture until day 3. At this moment, we collect the secretome, and we analyze by two complementary approaches the proteins that were released by mass spec. We obtain a total of 700 proteins identified in L-PRF secretome at day 3. Many of them were growth factors, as you can see there. We identified TGF-beta1, PDGF, and EGF, but many other proteins that we identify are related with platelet and neutrophil degranulation. When we check the canonical pathways where these proteins were implicated, we found acute phase response signaling that is implicated in inflammation, and also clathrin-mediated endocytosis. This pathway is very important because there is the mechanism through the cell communicate, and it's about growth factors go to one cell and the other. Also, we check the site expression of all these proteins, and not are only released by platelets, they are also released by many other cell types, leukocytes, specifically monocytes. So attending to the next objective, it was to identify the differential protein released by L-PRF membranes depending on the incubation time. So for that, we follow another approach. It's similar that at the beginning, of course, we collect the membrane, we culture, and we apply some washes at the beginning in order to eliminate plasma proteins such as albumin and immunoglobulins. And finally, we culture until day 3. In this moment, we collect the release of this membrane, and we add fresh media. We collect it until day 7, and we collect it again, this media, and we add fresh more. And finally, we collect it at day 21, like the time point end. And we analyze this following another proteomic approach that identifies these differences. And also, finally, we perform an additional experiments in order to corroborate the results obtained here. So in total, we identified 202 proteins that were differentially expressed over the time. The majority of them were enriched at day 3 and decreased over the time. It was the case of the proteins that I show here. In the case of thrombospondin, that it decreased, MMP9 and complement 3 that they also decrease. However, not all the proteins decrease over the time, and some of them increase, and it was the case of fibrinogen and also cathepsin S. In order to corroborate these results, we collect a new cohort of membranes from another donors in order that we see that these results obtained by proteomics were true. So as you can see here in this graphic, of course, thrombospondin decreased over the time, also MMP9, and also complement 3. And in 3 cases, they did it statistically significant between day 3 and day 21. Of course, we also corroborated what happened with fibrinogen and cathepsin S, and we see the same that we have measured by mass spec. These proteins increase over the time in this independent cohort of donors. So another thing that we want to check is growth factors, of course, because everyone wants to know what happens with growth factors. So we apply a kit in order to identify all these growth factors in samples of 4 donors, and we collected the secretomes at day 3 and day 7. Here we have the results. Green color indicates that these growth factors were found at higher concentration at day 3, and red color indicates the contrary. The other ones that are in white, it's difficult to get a conclusion if they increase or not, because with only 4 donors, there have a variability between one and the other one, so we couldn't conclude nothing. However, among all these factors, PTGF and EGF show higher levels at day 3 versus day 7. So a possible explanation of these results, we have it here. The majority of the proteins, if you remember, as explained at the beginning, the majority proteins are released at day 3 and decrease over the time. And these proteins are related with platelet and neutrophil degranulation. So it has sense that growth factors are enriched at day 3 compared to day 7. However, what happens with GDF15? The explanation is here. These growth factors is released by macrophages. At day 3, there are high presence of monocytes, but not macrophages, and there are going to differentiate it over the time in the L-PRF membrane. So finally, macrophages are in a more number, and of course, the concentration of this growth factor is bigger. So after identifying the proteome that these L-PRF membranes release, we want to know what happened with the effect on cells, and we want to check the processes in wound healing. As you know, phases of wound healing, in these phases, participates many cell types. However, fibroblasts are important because they participate in proliferative and remodeling phases. So we choose this cell type in order to apply our secretome. We evaluated 2 properties of fibroblasts. In first case, we evaluate proliferation, and if you can see, we apply a substrate, we apply a substrate that is yellow, and when it's metabolized by cells, finally it takes another color. But to check migration, we culture cells and we do a scratch, and finally we measure migration. Here in the next slide, I have a video. Here, as you see here, is now the gun made by a pipette. And after that, we apply the media, and cells started to migrate. And finally, they migrate enough in order to completely close the wound healing. So this is an example. Of course, all cells migrate. So finally, when we want to know if it's adding the secretome, the cells migrate faster than they do normally. So the first thing that we have to decide, it was what concentration of L-PRF secretome we are going to use. So regarding to the literature, we select this concentration between 1 and 20%. As you see, if we increase concentration, proliferation is increased. But in this moment, between 10 and 20, there is a decrease. However, this doesn't happen on migration. In this graphic, we take pictures every two hours, and we see that there is go, close the healing. But in this case, we see that 100% of secretome close faster than the positive control of 12 hours. However, when we check at 24 hours, all the samples have presented similar results. So there is a controversy between proliferation and migration, because if you can see, at 20% of secretome, the proliferation goes down. However, migration, they don't do it. So checking the literature, we decide that test another concentration, because probably 20% of secretome sample would be too much for cells. So in the next experiment, we decided to try another concentrations between 1 and 10. And as you see here, in this case, 3% of secretome was the condition that most proliferation performs. However, when we check migration, it wasn't the same. It was the concentration of 10% of secretome that migrates more than the positive control, and indeed they did it in a significant way. So on the controversy of these two results, we decided in the next experiment to try these two concentrations, 3 and 10% of secretome. So in the next experiment, finally, we collect secretome from 8 membranes from different donors, and we try these concentrations, 3% and 10% collected at day 3 and also at day 7. As you see in this graphic, in proliferation, it was a condition of 3% secretome concentration at day 3 that proliferates more than the rest of conditions, and of course, more than the control. However, when we check migration, it doesn't happen the same. This condition is not the unit that migrates more than the positive control. They did it also the concentration of 10% of secretome at day 3, and also they did it in a significant way. So what could be the explanation for that? Well, if you see here, both concentration at day 3 migrates more than the concentration at day 7. This could be related with the proteins that we identify in L-PRF. Of course, there are more proteins, growth factors, and also proteins that comes from platelets and neutrophils at day 3 than at day 7. So probably the amount of these proteins make more proliferation than the proteins that are present at day 7. However, if you see here, the same sample, day 3, apply a different concentration, doesn't achieve the same value. And in this case, 10%, it doesn't achieve more than 3%. So a possible explanation could be in the proteins that are there. One of them, it could be thrombospondin. Checking the literature, we see that some authors suggest that this protein could have antiproliferative effects, because concentration more than 1 microgram per ml in secretome could have antiproliferative effects. And they measure this protein in the platelet concentrate that they use, specifically PRP. And when they use it at concentration of 15% and 30%, it has an antiproliferative effect. And this protein is in a very high level. So due to that, this could be one of the proteins that is too much, in a too much concentration at 10% of day 3, and it could have a negative impact in this way. But it's not only, of course, this protein, because as you see before, we have 705 proteins, so it's impossible this one only have these negative results, and there are other proteins, other leukocyte origin proteins that could be related with antiproliferative effects. Now, to explain migration, in this case, as you see, of course, again, concentrate at day 3 will increase more migration. It's normal because there are more growth factors, as we say before. However, the 10% of secretome at day 7 migrates more and also in a significant way than the positive one. The explanation could be, again, in the proteins present in this case, that there was, if you remember, catepsin S and fibrinogen present more levels at day 7 compared at day 3. Again, checking the literature, we see that catepsin S, huge levels of this enzyme, correlates with a high capacity of migration of tumoral cells, and blocking this enzyme specifically diminishes the migration. And also fibrinogen, they have a benefit effect on fibroblast migration if they're found at plasma levels. So these two proteins are enrichment at day 7, and probably at the concentration of 10%, there will be in an enough amount to could promote migration. However, fibroblasts, there are not the unique cell types that participate in wound healing. And when we talk about fracture healings, they participate in other cell types, as for example, mesenchymal stem cells, osteoblasts, and also osteoclasts that are not here represented. So currently, we are performing, in collaboration with University of Oslo in Norway, some experiments that they are running just right now in order to analyze the effect of the secretome in bone differentiations, since the mesenchymal stem cells add in this secretome in order to see the differentiation to osteoblast and finally osteocyte. So after this big talk, I will want to conclude giving 3 ideas in order that you could take home. So we could say that proteomic data sheds light to the proteins that L-PRF release and show the reaction that are taking place in the biomembrane at each moment. Biological data contribute to understand the L-PRF properties on wound healing processes, and future research will provide more information to improve the application of the L-PRF, getting close to personalized medicine. So finally, I want to thank, of course, my lab mates from the group of platelet proteomics, also all the collaborators, especially Juan Blanco, and of course the funding, because this research could be supportive without them, and of course all of you for your attention. Thank you very much.
Dr. Lidia, thank you very much for your excellent talk.
Thank you.
We will see each other in a couple of hours when we finish, because I'm sure there will be some questions for you too.
Okay.
So thank you very much.
Thank you very much.
So now we are going to have our second presenter. Yes. I would like to introduce you Professor Marc Quirynen. Probably doesn't need any introduction, but I will do it formally. So he graduated in 1980 as a dentist and finished in 1984 his training in periodontology at the Department of Periodontology, both at Catholic University in Leuven. In 1986, he presented his PhD. In 1990, he was appointed professor at the Faculty of Medicine of the Catholic University in Leuven to teach periodontology and anatomy. His research deals mainly with oral microbiology, oral malodor, simplification optimization of periodontal therapy, including implant surgery, and of course benefits of the L-PRF technique. He published over 450 full pages and is a member of the editorial board of several extremely good dental journals. Marc Quirynen, Marc, it's a pleasure to have you here in this panel.
Thank you.
The floor is yours.
Thank you very much.
I'm sure that we'll enjoy your presentation. Thank you.
Thank you. Dear colleagues and friends, it's really a great honor for me to share with you some tricks, some guidelines to optimize the preparation of L-PRF. And I would like to talk about the preparation of membranes, plugs, and last but not least, about the L-PRF block. Of course, you know that the L-PRF membranes are prepared from the blood of the patient. So the first step in the preparation is to obtain some blood via a venipuncture. And here it starts already. At this stage, you have to use the correct tubes, either glass tubes or plastic tubes with a silica coating, because the contact between blood and glass is needed to start the coagulation. Also extremely important for you, my dear colleagues, to remember is that we will not add any additives to the blood of the patient. We will only perform a mechanical manipulation. But from a chemical point of view, the blood is not changed. And normally we will collect 8 tubes of 9 ml, but sometimes we have to go to 16. And then we have to put these tubes into the centrifuge. If you are working with the intraspin device, you have to put it at 2,700 rotations per minute. And this for at least 12 minutes. And if your patient takes some anticoagulant medication, you have to go to 15 or even 18 minutes. And there is one very important issue here. The time between collecting the blood and placing them into the centrifuge cannot be more than 1 minute. And that explains why we have to work very fast and why we have to load the centrifuge 2 by 2. And I will come back to that at a later moment. After 12 minutes of centrifugation, we have a beautiful separation between the red blood cells at the bottom, an acellular plasma at the top, and in the middle, the construct of interest, the L-PRF clot. You can grab this clot with tweezers, and then you have to remove immediately the red blood cells because they are not useful for the treatments or the indications where we are going to use the L-PRF. This clot has the consistency of a snail, an escargot, so it's quite weak. And now we are already at step 4, where we are going to prepare the membranes via a very gentle compression. Here we are using a glass plate just to show to you what is happening. And you can see that a lot of liquid is leaking out of these clots. This liquid we call the L-PRF exudate. And this is a nice product. It's poor in cells because they are trapped in the clots or remain trapped in the clots, but this liquid is very rich in growth factors and also has an antibacterial capacity. And we will talk about this later on. After 5 minutes of gentle compression, you will then finally obtain these beautiful membranes. To be honest, I'm really crazy about these membranes because also they have fantastic features. They contain a high concentration, 25 times higher than in the blood of the patient, of leukocytes and platelets. And now you can understand the activities that were discussed in the previous presentation. But they also contain a lot of growth factors. So just a little bit to summarize, time between taking the blood and obtaining the membranes is approximately 20 minutes. And these membranes can be used for the next 3 hours if you can prevent dehydration of these membranes. In fact, if you look to the consumables, it's not really expensive to make such membranes. Consumable-wise, you need less than 10 euros for 8 membranes. As you have seen, the technique is quite simple. You just have to think about this 1 minute. And last but not least, this is a 100% autogenous product. To summarize, you have the blood of the patient. After the centrifugation, the separation between the three. you can grab the clot, as you can see here, and here. And after compression, you will have this nice membrane, which is 3 centimeters by 1 centimeter and around 0.5 millimeter in thickness. Just like to ask your attention for this region here. That is the region where the clot has been in contact with the red blood cells. And this is the area underneath the red blood cells with the highest concentration of platelets and leukocytes. So from a biological point of view, the most active area. If you are thinking about the equipment, we have the centrifuge and the compression box that you can see here, the instruments. But what you also should pay attention to are these 3 white spots here. They are basically cylinders. You can put your clot in such a cylinder and compress it with this piston. And then you will get these beautiful L-PRF plugs, which are very useful in, for example, extraction sockets. If you are going to compress them, you have to make sure that the level of your piston is at the same as the level of the cylinder. Now, some details. As I already told you, the time between collecting the blood and starting the centrifugation should be less than 1 minute. And this has been tested by Myron and my PhD student, Ana Castro. They took some time between taking the blood and putting in the centrifuge of less than a minute, 1 minute, 3, 5, 7, and 10 minutes. And here you can see the corresponding membranes. And look carefully, my friends. Already after 1 minute, the membrane becomes smaller in size. And after 5 minutes, you are not able to get a membrane anymore. So you have to speed up. And in fact, you have to be able to get your tubes into the centrifuge within 1 minute. So this is the protocol that we would like to suggest to you. First, you collect your first tubes. You place them into the centrifuge. Make sure that the 2 tubes are opposite to each other. You start the centrifugation. And then you collect tube number 3 and 4. When 4 is nearly halfway, you stop your centrifuge. You wait until it is completely filled. You add it to the centrifuge, and you start the procedure again. The same for 5 and 6. And you also see which positions you have to select. And 7 and 8. Now the centrifuge is completely loaded. And, dear colleagues, now the time starts to run. From this moment on, you have to centrifuge for at least 12 minutes. The second question we were asking ourselves is, how long can we keep the clots into the tubes before preparing and condensing the clots into membranes? Well, these were the time intervals that were selected by Ana Castro: 30 minutes, 1 hour, 2, 3, and 4 hours. And what did we see? If you wait 4 hours before taking out the clot to prepare a membrane, you see that the clot is shrinking, and also that the gap or the difference between the clot and the red blood cells is disappearing. And here you can see the different membranes that were created over time. And again, you see some shrinkage of the membranes after 1 hour. So our advice is not to wait longer than 1 hour before you prepare the membranes. And this is a short video on the procedure. Here we are using the butterfly technique, which I love. By the way, this is me. You can see it from my belly. And here we are collecting the blood. I'm breathing a little bit fast, but it's just because the movie is in a faster production. So when the second tube is nearly filled, you see some last drops getting into the tube. You rotate your tubes. Why the hell rotate them? Because you like to have as much as possible contact between the blood on one hand and the inner surface to start the coagulation process. When all the tubes are in, you have to put it 2,700 rotations per minute for 12 minutes. Here you can see how you can grab the membrane, the clot, sorry. You remove the red blood cells. And you place it into the compression box. You have to do this very carefully. Don't cut this part away, because remember, underneath the red blood cells, we have the biologically very active area with the white blood cells and the platelets. Here we are using these cylinders to create these cylindric formed membranes called the plugs. These are very nice to be used, as I already told you, in extraction sockets and even in the sinus. It's a bit easier to apply, but this will be discussed later today. And now the clots are ready to be compressed into membranes. Just by covering it with this plate and then the cover. And you have to wait only 5 minutes. After these 5 minutes, you will get these beautiful L-PRF membranes. And the plugs. And what is also very important, here you see the structure of these plugs, that you should aspirate the liquid that has been leaking out of the clots, the L-PRF exudate, because, as I already told you, it has an antibacterial capacity and it also contains a high concentration of growth factors. In fact, a very nice liquid to store, for example, bone chips that you have collected during your surgery. Also important for you to realize is that on these tubes you will find a mark that shows the 9 ml level. And you have to make sure that all the tubes are filled up to this level. Otherwise, when you place these tubes in the centrifuge, it will start to vibrate and you will not have this beautiful separation in the 3 layers that I have shown you earlier. Once I had tubes like this, and I was asking myself, what the hell, how does it come? Tubes that are only filled for 50% was not normal. And then, when I was looking to the backside, I realized that there was an expiration date. An expiration date for tubes? Does this really exist? Yes, indeed. Because it is, of course, not talk about the tubes by itself, but about the vacuum. If you wait too long, the vacuum will slowly disappear. So check the expiration date of the tubes. And please also check the volume when you take the blood. Now about the centrifuge itself. I have already mentioned that you should always prevent the vibration. And that's why you have to put such a centrifuge on a stable table and not on a mobile table, as you can see down here. Of course, you have to prevent an imbalance during the centrifugation. It might be wise to have one tube aside that filled with water up to the 9 ml level, in case the draw of blood is very slow, and you can use then this one to put across the other tube to keep your centrifuge in balance. And also extremely important for you, dear colleagues, is that you always have to use the correct setting. And the correct setting is 408 G-force. For example, another frequently used centrifuge is a duo process from Quirynen. This has a wider radius of the rotor. And if you would like to get this G-force, you have to reduce the speed, the rotations per minute. Okay, now we have reached the L-PRF bone block. The first step in the preparation of the L-PRF bone block is to take two membranes and to chop them very well. We need these chopped membranes because they contain a high concentration of activated platelets, which we need in the next step. Make sure that you really cut it in nice and small pieces. Then you are going to mix the bone substitute with the chopped L-PRF membranes. And the perfect ratio, as far as we know, are 2 membranes for half a gram of a bone substitute. Make sure that you have a nice homogeneous mixture of the two. Then you collect liquid fibrinogen. To prepare this liquid fibrinogen, you need a different type of tube with a white cap. It is a tube with an inert surface on the inside in order to delay the coagulation. It's the opposite of the red cap tubes. Red cap tubes are promoting the coagulation via the glass or the silica coating. White cap tubes have an inert surface to delay the coagulation. So you can simply aspirate this liquid fibrinogen. And in fact, you can use these tubes during the same cycle of centrifugation. And these tubes only have to be spinned for 3 minutes. But that will become clearer later on. The only problem that we have, dear colleagues, is that you only have 30 minutes to work with this liquid fibrinogen. And what is going to happen when we apply this liquid fibrinogen towards our mixture of bone substitute and chopped L-PRF, you will get the spontaneous formation of a nice block. Why? Because the activated platelets are going to convert these small fibrinogen chains into a very beautiful 3D fibrin network. And this block is quite strong. In fact, it has the chemical properties or characteristics of gummy bears, the candy that you probably know. And such a block even has an intrinsic memory shape. I will show you later on. So please remember a good ratio would be 2 membranes for half a gram of substitute. Also, what is important to know is that when you are mixing, when you are stirring the 3 components, be very gentle. We know that if you are too aggressive, you will end at the end of the day with scrambled eggs instead of an omelette. Well, it's the same with the L-PRF bone block. To summarize, 2 membranes, the bone substitute, chopped membranes, mixing them, collecting the liquid fibrinogen. You apply it towards your mixture, and you will get this beautiful bone block. This is, for example, a tube immediately after collecting the liquid fibrinogen, and this is 30 minutes later. And look, inside of this tube, you see the creation of a kind of a fetus, I could say. And when you see this liquid fibrinogen will no longer form a nice block. And once you have prepared this block, you can use it easily in the next 2 to 3 hours. Again, if you can prevent dehydration. And here you see a short video. As you can see, again, it's me here, being a bit nervous because this technique I do not really like. Filling the blood tubes. I prefer, as you already heard, the butterfly technique. Feels better. Collecting blood tubes. Rotating to have the best contact between blood and inner surface. And at the end, we collect the white cap tubes in the same way. These, of course, we do not have to rotate because there is no need for contact. Then we put our centrifuge in for 3 minutes. And after 3 minutes, we obtain this nice liquid fibrinogen. And we can continue the centrifugation for the remaining 6 tubes for another 9 minutes. Here we are collecting the liquid fibrinogen. All very easy to use. Then we are going to prepare the L-PRF membranes from the remaining tubes. So here we have our membranes. Now we have to take 2 of them. Which we then chop in very small pieces, as you see here. Spend a bit of time to this, and when I'm going to talk about the L-PRF bone block, you will understand why. You add your bone substitute. A nice homogeneous mixture, also important. Otherwise, you will have later on in your L-PRF block large areas with only one or the other product, which is not preferred. Now you apply this liquid fibrinogen. Make sure that it gets everywhere, so you have really to try to get it inside of your mixture. And you already start to see the jellification here. And here is your L-PRF bone block, which you, of course, still can cut in pieces. And this shows a bit the form stability. So, as I have tried to tell you, the preparation of L-PRF membrane plus block is in fact quite easy. but you have to follow some simple guidelines. For example, use the correct tubes, think about time, the correct centrifuge also, and the correct setting of the centrifuge. And last but not least, do not forget that these L-PRF membranes are 100% autogenous. Thank you for your attention.
Thank you very much, Marc. It was splendid. So we are now moving to the other side of the Atlantic. And I can see that Professor Nelson Pinto is online and ready for his presentation. So welcome, Nelson, welcome to this global symposium. And if you allow me, I will start just giving a small introduction. Professor Nelson Pinto graduated in 1985 and is the founder and chairman of the Research Center for Tissue Engineering and Regenerative Medicine in Chile. For the past 30 years, he maintained an active private practice specializing in advanced oral implantology. Currently, Dr. Pinto is associate professor at University of the Andes, Chile, Department of Periodontics and Implantology, and visiting professor at Department of Oral Health Sciences, Periodontology, University Hospitals at the Catholic University in Leuven, in Belgium. He's a world-leading expert in L-PRF, soft and hard tissue regeneration, and wound healing. Among his many accomplishments is the development of a natural guided regeneration therapy, which received the following awards. Best Oral Research Presentation by the World Union of Wound Healing Societies in Yokohama, in Japan in September 2012. Best Contribution to Clinical Research of years 2013, 14, 15, and 16 by the Journal of Wound Care and World Union Wound Healing Societies Award in Florence, in Italy, 2016. And in 2018, he received the Quirynen Humanitarian Service Award in recognition of his humanitarian service in the chronic wound healing domain for his relevant technology, natural guided regeneration, therapy that is helping many patients change their lives. And this was in Kathmandu, in Nepal. So, Nelson, thank you very much for being with us today. Hopefully next time it will be face-to-face. And we are going to hear your first presentation on clinical indications of L-PRF, which is basically directed to reach preservation. Nelson, the floor is yours, and thank you.
Thank you very much, my dear friend. And I really miss to be there, but I hope we will have a really nice occasion to be all together and share a very nice time. Thank you for this invitation, and thank you for to BioHorizons, Camlog, SEPA, and this great bone regeneration online global summit that I'm sure will clarify many things about bone regeneration, and especially focus on L-PRF that I hope it will also bring a lot of answers to many questions that I'm sure many clinicians around the world have today. So my topic is about root preservation. It's a very complex and very also polemic until today topic. So, but it's our daily clinical work that we face every day in our clinics. Patients come with the problems of they are losing teeth, and sometimes the condition of after they lose the teeth, even if they are in the front area or in the premolar area, that are also compromising, as Jill already presented, the area connected with the sinus. We see many problems, and usually we see loss of bone, loss of soft tissue. So those are the main issues that we face every day in our clinical daily practice. How to solve a case that it could be just one tooth or could be several teeth. So in all of those cases, we have the problem of losing soft tissue and hard tissue. And it will lead, and we look for the literature. We already know that, if we don't do anything, it will be an horizontal reduction and a vertical reduction after the extraction. That's will vary among patients. It will also will be different, depending on what type of tooth will be extracted or what is the technique that we're going to use. But anyway, the techniques aim to, for ridge preservation, try to maintain the ridge profile, or also maybe enlarge the original ridge profile. That's two different things, but those both things can be happen at the same time, but has to be under very specific indications. We also know that any of the technique that we use for ridge preservation can reduce vertical dimension and compare to vertical and width compared to non-assisted socket healing. So we know that if we do something, we can reduce the horizontal and vertical reduction of the ridge after the extraction. But the problem is that no evidence has been identified to really, specify what will be the best technique that we can use, or what would be the best biomaterial that we can use for these cases. If we look for the Cochrane review in 2015, well, all the conclusion about that revision is that there is limited evidence for any of the ridge preservation technique, no evidence for, if this will really improve the outcome of the implant therapy, and no convincing evidence for any technique that really will help us. The funny thing is, or not funny, but also interesting, is this is the review, the update of that Cochrane review in 2021. This is from March 2021, and the conclusion are exactly the same, just a small change that, now it can be accepted that we need to do something, because there is enough evidence to say that if we don't do anything, then we will have a reduction in the contour of the remaining ridge. But there is no evidence until today about what will be the best technique or what will be the best graft material that we can use. Problem is, in any of these reviews that are related to xenograft versus extraction, allograft versus xenograft, alloplast versus xenograft, and alloplast with or without membrane, there is no mention to any study or no mention to any clinical trials about using blood derivatives. So we are just talking about biomaterials or regular technique for GBR. So several systematic reviews have been published, and despite the lack of strong evidence, L-PRF might have a positive effect on the bone regeneration and osseointegration. And another one shows that L-PRF reduced the magnitude of vertical and horizontal bone resorption. And L-PRF as a potential material of choice for ridge preservation procedures alone or in combined with biomaterials. Now, also the L-PRF prevented both the horizontal and vertical crestal bone resorption, even better than if we use some demineralized bovine bone. So even we need more randomized, very good controlled clinical trials, there is some evidence that shows, how important it's getting L-PRF into this domain. But the problem is, as Marc shows, and we already also have been talking very well, the importance of protocols. That it's also highlighted in this systematic review, that highlight that there is a need for, emphasize on the application, the standardization of protocols and preparation from these autologous products. This is the only way that we can really get a good data and to really can compare different clinical studies. So we need to stay with a real good protocol, and everyone follow exactly the same. As Jill told at the beginning, he followed a protocol for wound healing, and he got exactly the same result that we have been achieving everywhere in the world that this has been applied. So for that reason also, we try to contribute with these guidelines to show, Marc already showed very well why there is a need for a very good protocols and guidelines. And this can be found in different languages. And we want to contribute to that, to establish a really specific protocols of how to prepare, how to use it, and how to apply it in specific situations. So there is also in basic science, there is an evidence that demonstrates that L-PRF can stimulate osteoblast proliferation. And already Lidia also showed very nice results with the proteomic study that are running today. Also, L-PRF suppress osteoclastogenesis. And the application of L-PRF may provide the benefit for bone regeneration. So this is very important because bone regeneration after extraction is a very complex procedure, a very complex process. So L-PRF, how L-PRF contribute in this complicated network of various cell types in this bone microenvironment is very useful to know how. We know also that L-PRF, promote the addition, the proliferation, and the differentiation of MC3T3E1 cells. Those cells have the capacity to differentiate into osteoblasts, osteocytes, and have been demonstrated to form calcified bone tissue in vitro. So L-PRF membrane also can inhibit the formation of osteoclasts. Has also been, this is presently researched. And the favorable effect of L-PRF membranes in alveolar risk preservation may be attributed, at least in part, by the inhibition of osteoclastogenesis. So L-PRF membrane can preserve alveolar risk dimension after tooth extraction through this mechanism. This is one of the mechanisms. Also, L-PRF holds an anti-inflammatory activity. And one of the important things that we know also today, that is getting a lot of importance, is that also can shift the macrophages polarization from an M1 towards an M2 phenotype. So we know today how important it is to take a good vision about the, how macrophages are taking a key role in bone regeneration through, bone repair, the stimulation of the angiogenesis and arteriogenesis to the side, how they can stimulate progenitor cells or differentiates, and how they modulate the host response to every biomaterials, any implanted material that we put in the site. So this finding, this finding suggests, and also in animal studies, they suggest that this is very definitely an animal study that showed that L-PRF stimulate natural process of tissue healing and regeneration post-extractions. This study was done in dogs. But this is one of the very nice studies done in humans. It was done in 2013, I think. And it showed that the L-PRF membrane, when they fill the socket after tooth extraction, led to improved alveolar bone healing with a better preservation of the alveolar crest web. And what this really highlights, it's very important, is that the procedure, the surgical procedure, seems to be as important as the grafted material. So this is why we used to say, when you would like to use L-PRF for any surgical procedure, you have to think how to use it right to get the most benefit of this wonderful biomaterial. You cannot do exactly the same that you have been done. So this shows very well that if you combine, or depending on what is your surgical approach, may change the final result or the final outcome. So it also shows that the intrinsic quality of this bone that you can achieve with L-PRF will be much better than the bone that you can get from an spontaneous healing through just a blood coagulum. Even we are talking about exactly the same blood of the patient. One is a regular coagulum, and the other one is a special coagulum, a super coagulum, super cloth, that we manipulate the blood in such a way that we can use it in the site. And it shows very clear, and this has been reproduced also by other studies, that the quality of the bone by micro-CT analysis, it's much better when you use L-PRF alone, and especially when you don't make a flap. So the approach and the surgical approach that you do in the site also can make a big difference on the outcome if you only use L-PRF. So after several years, also this EAO consensus meeting include, ridge preservation and they evaluate the use of this platelet concentrate in 2018. And it was very interesting to show and to see that, the conclusion was that, PRP has shown no benefit in different clinical approaches of implantology and also for ridge preservation. And the use of PRGF has not shown any benefit for ridge preservation. But they opened the door now because they accept that, or they conclude that the use of PRF have been reported to be beneficial for ridge preservation, to improve osseointegration, and also to use it in the treatment of peri-implantitis. So now this is some of the study for ridge preservation that we did in our university. This was the first pilot study that showed exactly the same result with the randomized controlled clinical trial that we did in conjunction with the University of Leuven. Actually was part of the first study that they were running at the beginning. It was already published in 2016 that shows exactly the same thing, of that this is a reproducible technique, predictable technique, but you have to follow exactly what are the basic protocols. And it shows that after 3 months, the socket bone field is significantly better in the site where you use L-PRF versus the control site if you do spontaneous healing. Horizontal ridge resorption also is significantly less on the site where you use L-PRF. Vertical ridge resorption also significantly is better on the side, or is reduced on the side of L-PRF treatment. So L-PRF is improving, and again, this also has been reproduced and replicated again. Micro-CT analysis of the bone quality that you can get when you use L-PRF on the side is also much better compared with the spontaneous healing by just blood coagulum. Even we are talking exactly about using the same blood of the patient. So this intrinsic bone quality, it is very important, because if we are planning to place an implant in this case, this should be a very important issue. So for ridge preservation, conclusion can be that you can get less post-op pain, more socket fill, a good quality of bone. The quality of the bone is much, much better than regular bone that you can obtain by any type of biomaterial or just by a spontaneous healing, and you can get less bone resorption after the extraction. So again, if we review the literature, we will find that there is some publications that are really in favor of using L-PRF for ridge preservation. And other ones, that they show that there's no benefit or there's a significant benefit, and there is no indication to use L-PRF for ridge preservation. But the problem is that if you really have to take care and look at how these studies were done, and what you will find is exactly what I already show you with the systematic reviews. There is no consensus on how much to use it, how to use it, and what is the technique, especially how to seal the socket. That this is important part, one of the most important part of the procedure that I will show you in a few seconds. So this is important to know why sometimes work, why sometimes it doesn't work. It usually is because of this confusion, of lack of information, and lack of consensus about how to use it right. So this is the typical case where you have a big bone defect, no bone walls on the palatal side, on the buccal aspect. So if we try to solve this case, of course, there will be many techniques, but we are going to use it only L-PRF in this case to try to create enough bone to place an implant and to rehabilitate this in just 4 months. So this is how the socket filled with L-PRF will look immediately after the extraction. And this is how it should look after 1 week, where the L-PRF is still there and the socket is sealed all the way around. So it will stop the migration and also will stop or will inhibit the contraction through the mechanism of the myofibroblasts to avoid the pressure and to allow the formation of good gingiva and good enough amount of bone underneath of that gingiva. So this is how it looks at the baseline. We can see that we don't have enough amount of gingiva, not too much keratinized tissue in the center. But if we wait after 3 months, well, this is a completely different look. And we can see in the combing CT, right immediately after on your left and after 4 months on the right, we have gained enough amount of bone to place an implant without a flap and to do immediate load and at 4 months deliver the final crown. So if we see the type of bone that was created in that site, this is what we look like. This is the video microscope on the top and the histology on the bottom. And you can see this is a very nice, good quality of bone. It's a living bone, very vascularized bone. This is one of the typical features of this type of regeneration. The bone quality is also expressed by the good vascularization of the bone, better vascularization than regular bone. And this is the crown. That's the baseline, the crown. And this is the control combing CT after 5 years. And we can see that the bone quality is still okay, remain exactly the same. And this is many people say that we don't have enough control in the long-term data, but this is the 10 years control of this case. And we can see after 10 years that the bone quality still the same, has been stable, has been dynamic, has been reacting to the occlusal forceps. So this is a dynamic bone, this is original bone, and cortical bone has been now equal to the original cortical bone. So one of the questions that should be answered is if this L-PRF can be used really as an autologous membrane or can be replace some of the membrane that we already have to use it, and produced by different procedures. Well, the answer is yes. The L-PRF can be used as an autologous membrane and promote bone healing. And also L-PRF yields better clinical results compared to collagen membrane. This is a very nice study that shows that compared to resorbable membrane, it reduced the fibrosis and increased the amount of bone. And also there is a lot of confusion if the L-PRF can be or play a role as a barrier membrane. And this is a very smart biomaterial because it can be used, it play an effective role as a barrier membrane. It's a biological membrane that also may lead to be as an excellent barrier membrane in place of other non-resorbable and resorbable membrane. And L-PRF has been more effective in bone regeneration when compared to non-resorbable and resorbable barrier membranes. So this is at the time to discuss and to show, what happened to this membrane. This type of membrane, if you follow this protocol, is already Marc showed very nicely, is why this membrane will not dissolve, will not go to fibrosis, will not disappear in the short time. So we have this case, this is the baseline, this is after 5 days. After 5 days, we can see that the suture that was put there, and the suture was put in such a specific way, just to hold everything in place, not to try to attempt primary closure. That would be a big mistake. And after 5 days, we just can see what is remaining inside that the socket, the seed completely filled. And after 8 days, exactly the same, but it's changing in color and changing, you know, and how the aspect of the L-PRF inside the socket looks like. And after 12 days, we can see that this is bleeding already. And we can see that the size at the area of the entrance of the socket remain the same because there is no contraction. There is no contraction through the myofibroblast. There is no need for that. And this allows this L-PRF, you know, to start to evolve to a new tissue. And you can see after 21 days, we can see the evolution of the L-PRF through to a new tissue. And in the center, you can see that we still have the original L-PRF that was put there. So this has not been resolved. It's just evolving through, you know, the formation of new tissues. So this is just to show how good is the irrigation of the area. After 28 days, we can see that this completely healed. After 3 months, we can see that we have gained soft tissue, keratinized tissue, and we have gained bone, enough bone to place a 6 millimeter diameter implant that it maybe is not needed, but just to show that we still have 3 millimeter of bone on the buccal aspect where there was no bone before. If we see the histology of that quality of the bone, we can see from the crescent of the ridge all the way up into the sinus that this bone is a perfect bone to place an implant, and it shows complete regeneration of all the characteristics of the ridge in that area. This is the X-ray of the implant immediately after, and after 2 years that have been in place, we can see that also the bone has been improving over time, and this is the clinical aspect of that crown after 2 years. So now we are going to have even a more complex case, because now we don't have any, it's completely disappeared, the floor of the sinus, so we will be able to see what happened. And we all know that in this case, there is a lot of risk of having an oral antral communication. And the ridge, of course, if we don't have buccal plate, will remain, or it will be maybe not too good at the end. So we do the extraction. And again, exactly, we can reproduce, we can predict, and we can see exactly what we have seen before. And we gain keratinized tissue, we gain soft tissue, we preserve what it was there. And after 3 months, we have more than enough bone to place an implant. Sinusitis is gone, and we can place the implant. And we will do also the histology in this case after 3 months. We get those 10 millimeter of bone all the way from the crestal of the ridge up into the sinus. That's on your right, you can see the sinus mucosa. Those are the 10 millimeters. And again, we see new cortical bone at top of the ridge, very nice trabecular bone in the center, and very beautiful new floor of the sinus with the sinus mucosa. So we have been able to regenerate all the structures that were missing there from the soft tissue and the hard tissues. And we can see that we will have more than enough soft and hard tissue to place a crown. And this is the 2 years follow-up, very stable crown from the functional and aesthetic point. So now we will see another case, more complex. Again, we don't have any part of the buccal aspect all the way up to the apex. And then this is how it looks like. Exactly, we do the same. We follow the guideline for the natural guided regeneration therapy that we have been shown, we have proposed through these guidelines. So you follow this protocol, you should get after 3 months, exactly what I'm showing here in this video. You can see after 3 months at the reentry, there's more than enough bone, exactly how you see on the CBCT on your left. So we are going to extract now, just to show you directly in this video, that we are going to take the core sample. And this is something that you cannot do when you have a bone biomaterial because it will break. But this quality of bone, as we have seen, the quality of this bone is very strong, very elastic, very vascularized, so it's able to get the sample like this. And this is the histology of the sample after 3 months. It shows exactly the same that I've been showing all the previous cases, and we have been showing in every case that we see or we follow, we see exactly the same. We see from the left to the right is from the ridge to the top. We see bone formation, very nice trabecular bone, living bone, and you can see that is after 3 months, we still see some remaining L-PRF that is now transforming into bone. So even after 3 months, we will continue to get more bone. So in this case, we can see from the coronal view how the buccal plate has been regenerated. And this is a micro endoscope to see that we have almost 3 millimeter, 2.7 millimeter of bone on where there was no bone at the beginning. And we have placed the implant in the right position. And if we look in the lateral view with the endo microscope, we can see that the quality of the buccal bone is exactly the same as the original buccal plate that we will see in the rest of the ridge. So this shows that we are able to really regenerate all the missing tissues that were there. And this is the control right after the implant placement. This is the after 3 months. We can see very nice soft tissue, very nice bone quality. So this also, just to say again, once again, L-PRF can help you to regenerate soft and hard tissues. And this is the control after 3 years. And we can still see, sorry for that, we can still see after 3 years how stable is the bone and how the dynamic processes that go through this bone after the implant placement. It is because this is original bone, and how stable will stay over time. It is because of it is original bone. So just to share a couple of cases that this can be done by anyone if they follow the rule. This is what the first case that was done by one of my students, first year in the implant program. It has this very difficult case, canine, infected, huge recession, no bone all the way to the top. So after the extraction, you see a big defect, but he will follow exactly the procedure and the protocol. And also the suture, it's very specific in this case. You cannot suture where there is no bone. You have to suture in the area that is supported by bone. So now you put a provisional, and this is the CVCT. You can see there is no bone. This is just a floating tooth has to be extracted. And now, after 6 months, because of the pandemic, we couldn't get it at 3 months, but we know that 3 months the bone that should be there. So after 6 months, we have enough amount of bone to place an implant there. And just to finish, in another country from the US, this case was sent by a good friend, Leonardo Granado, that attend one of my courses. And this actually is his wife. And he sent me this case. And he said me, what can I do in this case? I want to do the best for my wife. Well, I said, do whatever, everything that I have taught you. Use L-PRF as a soil graft. That would be the perfect indication. And he was very scared. And you can see that even for his wife, he took a CVCT every month. And we have the opportunity to see the evolution of that situation over time and see after 1, 2, 3, and 6 months. And what we get after 6 months? More than enough bone, good quality of bone, good quality of the tissue to place an implant. So how's it used to be said, sometimes people is very skeptical about things that are completely true, but sometimes it's because we just don't know. But just to finish, the only thing I can say is that L-PRF create bone. It doesn't matter whatever or whoever is saying around that L-PRF has nothing to do with bone, but L-PRF create bone. And when no one can prove the contrary, you have to accept the simple truth. So thank you, my dear friends, for the opportunity to be at least through online and to share this knowledge with you. Thank you very much.
Thank you very much, Nelson. That was a wonderful presentation. Please stay with us because you're still going to have to present wonderful things to us. Next speaker. It's kind of weird to me to be in Santiago and introducing the owner, who's more brother to me than anything else. Professor Juan Blanco, professor in periodontology, the School of Medicine and Dentistry at University of Santiago de Compostela, is the director of the Master of Periodontology and Implantology, the continuing education program in periodontology of the university here in Santiago de Compostela, member of the International Research Committee of the ITI, past president of the Spanish Society of Periodontology, the SEPA, that is welcoming us today, past president of the ITI Iberian section, and also past president of the European Federation of Periodontology. Juan Blanco is going to talk to us on sinus lift and 3D augmentation. Juan, it's a pleasure. The floor is yours.
My pleasure.
Thank you very much.
With this kind of moderator. So thank you very much, Jill. It's a real pleasure to be at home and for sure to share again at least not much quantity of people on site, but hopefully things are currently changing. I try to be as fast as possible because time schedule is very important for people who is online, not to get bored, and I will try to be sharp. Next indication, as you can see in the screen, is about sinus lift and 3D augmentation, bone augmentation. What can today these new technologies, let's say new technologies, this L-PRF, second regeneration of platelet concentrates, can mean for clinicians as a added value? And let me start with two randomized clinical trials. The first one is the one you can see in the screen by the group of London. They have treated 30 patients, 26 maxillary sinus lift in a randomized split mouth design. They have used as control the reef bovine bone mineral as control, and as a test group this DBBM plus L-PRF. The way they have prepared this L-PRF block is according to Dohan et al. In 2006. They have used collagen membrane to close the lateral window with a follow-up of 6 months, and they have as primary outcome, as primary variables, the histological and histomorphometric analysis. What about the results of this study? You can see here in this table the new bone formation and the residual bone graft, the particles, that there were no difference between the groups. So clearly the conclusion with this kind of L-PRF technology is clear. There is no difference between both groups during 6 months of healing. But let's say the second randomized clinical trial from a group from Brazil 1 year later is the same study design, 12 patients, 24 maxillary sinus lift, again the same study design, a randomized split mouth design, the same comparison, the control and the L-PRF test. However, in this case, they have used for preparing the L-PRF block 1 L-PRF membrane per 0.5 grams of biomaterial, something that in the other article, in another paper, is not clear. They have used also collagen membrane to close the lateral window with a different follow-up. They have used a follow-up of 4 months for the test group, but 8 months for the control group. Again, the same primary outcome. And what about the results? Totally different comparing with the other study. You can see clearly here that the new bone formation in a 4 months follow-up for the test group is statistically significant with new bone formation with respect to the control group. And also, when we compare the quantity of residual bone particles with 30% here and almost 4% for the test group. So in this study, we can see clearly that the addition of this L-PRF is something important, producing or allowing to install the implants in early placement at 4 months, comparing with the control group at 8 months. So again, there are some differences using the same biomaterials, but probably the protocols are slightly different. And this is, I think, very important, as my colleagues have already just mentioned in the lectures before. If we go to this meta-analysis after a systematic review, this meta-analysis in 2019, they have analyzed 5 papers, and here clearly we can see that the new bone formation percentage, although there is no significant difference in this systematic review, but favors for the PRF technology. And also when we are measuring the residual bone graft percentage particles. So the conclusions are again very clear. We don't have a statistical significant difference with this systematic review, but there is something there that in the last systematic review that has already been published, the authors conclude that the combination of these both biomaterials can accelerate the healing, so also the time of dental implant insertion. We all know that the healing of the sinus procedure is going to be obtained after 6 months, but we want to try to have a shorter time probably with this technology, using these proteins, these active proteins, in trying to induce this new bone formation and accelerating this new formation, even in the cases we use some biomaterials for producing this L-PRF block. Also important to say, when we are talking about sinus lift, another utility for these L-PRF membranes is when we have some perforations, we can use these kind of membranes to close and to, let's say, to suture these holes, this perforation, as clearly you can see in this paper. So let me, from now on, show you some clinical cases, and I think this is very important in Incorporate Forum to talk about how we deal with this product. I introduce you, this patient is a female, 48 years old, is a patient that you can see in the OPG X-ray with periodontitis, no systemic diseases, no smoker. This is her smile with the intraoral clinical view, with some diastema, some inflammation in the gingiva. You can clearly see a thick phenotype. The diastema in the upper jaw. Also, we can see clearly the wearing of the tooth, some inflammation, some plaque retention also. The occlusal view in the upper jaw, the occlusal view in the lower jaw. And if we go to the CBCT scan, we can can see that we don't have enough bone availability in the posterior zone, in the zone of the sinus. On the right side, as you can see on the left side of the screen, comparing also, again, with this little bone availability on the left side. So in this patient, we have to go to a bilateral sinus lift approach that we do it with this technology, the L-PRF block, according to the preparation that Professor Quirynen has just shown us. And we prepare, according to this protocol, the L-PRF block. I'm going to go faster with these slides because are already clearly known. Once we have the L-PRF block, we prepare the sinus, we fill the sinus with this, let's say, biomaterial, and finally we cover this lateral window with another L-PRF membrane without using collagen membranes. We do this protocol, this approach in the bilateral zone. And one thing is clear, even we don't have, just in the case we don't have any added value in terms of histology, if we just pay attention to the paper by the group of London. But clearly, we have to talk about PROMs, patient-related outcomes measurements. And for the patients, if you are going to use less quantity of biomaterial and no collagen membrane, I'm not going to say any more about costs. So this is the result 6 months later. On the right side and also on the left side, the patient needs to follow the treatment plan that we have prepared. So the patient has to go through ortho treatment, and once we finish the ortho treatment, we go immediately to the installation of the 3 implants on the left side of the patient and 2 implants on the right side of the patient. And this is the end of the rehabilitation. After finishing the case, the whole treatment plan that we have prepared beforehand, the smile of the patient, the intraoral view, once we have also reconstructed the front area with restorative dentistry also. We have the right side, the left side with the bridge, and also with the X-ray, where we can see clearly that even in the zones where we have leave the sinus with this L-PRF block, the pre-implant crestal bone can be maintained. Let me share with you the second case. Is a woman, 79 years old, no smoker with some systemic problem, but under control, no allergies. Is a patient that she supports removable full dentures, you can see in the image. And on the right side, you can see the OPG X-ray, where in the CBCT, clearly we are able and very easy to see the bone availability on the right side. And if we go from the sinus to the front line, clearly we see that from an horizontal point of view, we have a very important defect, a very high demanded defect to be reconstructed. And we go to the left side now, the front area, the left side, and again we see the problems that the patient has in this left side in terms of bone availability. So in this case, we have again gone with the L-PRF block for sinus lift, but for this bone augmentation, we are probably from 5 years ago trying to use another protocol. And in this case is the use of allograft blocks digitally designed. So this is very important to understand that the blocks are has to be perfectly fit to the bone defect. That these allograft blocks are previously prepared, previous to the surgery, the block on the left, the block also in the right, with you can see the quantity of bone that we are going to use in this patient. And I'm going to show you this. I'm going to show you this video. If it works, I hope it's going to work. Yes, it's working. You can see that this surgery has been done in November 2018, so almost 3 years ago. We proceed with the surgery. You can see the incisions in this patient, in this upper right jaw. We lift very gently and carefully the flap. We have to detach the periosteum from the bone. We prepare the sinus as we usually do with a high-speed handpiece and a round bar, a diamond round bar. We lift and detach the membrane. The patient breathes, the membrane is moving. We prepare again with the same protocol, the L-PRF, 2 membranes per 0.5 grams of biomaterial. We introduce the biomaterial inside the sinus in a very easily way. We pack the whole L-PRF block inside this hole, inside this sinus. We pack it perfectly, very gently, and once we finish, we go for the bone augmentation in this anterior zone, anteriorly to the sinus lift that we have already done. We prepare, we hydrate the very important every step, of course, to create this bone augmentation with the corticate, the bone plate. We go to the bone marrow of the maxilla. We clean everything. We try this block graft preparedly designed digitally with these DICOM images coming from the CBCT scan. Then once the block is perfectly fit, and this is very important to reduce resorption of these kind of biomaterials, we fix with this screw these allograft blocks. And once we finish, we also hydrate the block with the L-PRF exudate coming from the membranes. We close all the gaps between, or all possible gaps between this block and the bone of the patient. We cover this block with these L-PRF membranes that are before prepared. You know exactly the time that we have for working. On top of this L-PRF membrane, we go for a collagen membrane, and we fix perfectly and very tightly this collagen membrane. We prepare the flap to cover everything in a very easy way, without any tension. You have to release the flaps. We go for the left side. We extract the molars with with an impossible prognosis. We rotate again the block, and the same procedure for the left side. We go again with the screws, we fix it. Clearly, we check the fit, how the block fits the defect, the horizontal defect. We fill all the gaps, and finally, we close everything in the same way as we did in the right side. So this is the image 10 days after, and the other side is 3 weeks after the healing. Everything is perfectly healed. The only problem with this patient is the provisional prost, where we have to use a removable one without any compression of the places where we have used these blocks to avoid resorption. 6-7 months later, this is in May 2019, we go for the implant installation, and hopefully it can go. Yes, this is the bone we obtain after lifting the flap, after the surgery. 6 months afterwards, clearly no resorption on the buccal aspect. We eliminate all the screws. As you can see here, we take out both screws, and according to the pre-prosthetic treatment plan, we proceed to implant installation with surgical guide that at the same time is going to be used for immediate loading. So we are going to install in this patient 80 implants and immediate loading in a bone that we have already augmented and without any autologous bone. This is important to say. We use these implants. We check everything step by step. We have to check also the surgical guide to check the different positions of the implants. We use different shapes and types of implants in the zone of the sinus lift, and in the front area we have also done the bone augmentation. We finish the case. We always use the definitive abutments in the surgeries. This is the one-time, one-abutment approach, and in the same, in the lateral, in the left side, we use also the same protocol. So this is before, this is after the bone augmentation technique, and this is how it looks after the 8 implants recently or just installed. This is the image where you can see the 8 implants and also the provisional immediate loading. The CBCT scan where you can see the profile of the bone in every one of the implants. You can say from the right side to the left side. And this is 1 week later, where we have to remove the prosthesis to eliminate all the suture, all the stitches, the smile of the patient. This is 3 weeks post-treatment. And finally, we go to the definitive prosthesis. This is the smile of the patient. This is the hybrid prosthesis that we have done in our patient. The x-rays, the periapical x-rays. Some months later on, the smile of the patient, the front view, the lateral view, the clinical aspect where we can see perfectly how the gums are totally healthy. Again, the prosthesis inside, and this is the difference between October 2019 to April 2020. And this is 2 years after implant installation. The implant installation was done in May 19, and you can see clearly how we can perfectly maintain the bone in the pre-implant aspect of the 8 implants. And let me show you a more demanding case. This is another patient where you can see in the OPG X-ray where is almost flat. There is no alveolar ridge in the right side. You can see that the palate is totally flat. And we check the CBCT scan, and clearly you can see here that there is no alveolar bone. And in addition, the sinus is going to be positioned in a cranial situation with respect to the nasal fossa. So this is a very complicated situation to do a sinus lift because the crestal is here and the sinus is going in another direction. So in this case, there are probably 2 possibilities: to do zygomatic implants, or to do, in my opinion, something that is easier, at least in my hands. And you can see the last CBCT scan before the treatment, and we go with the same technology, this allograft digitally designed with L-PRF membranes on top of it. This is the first surgery. We lift the flap, we can see and check the osseous crest, where in some places there are some communications as you can see here, this is a hole that communicates the alveolar aspect with the nose, and perfectly you can appreciate how flat is the palate here. There is nothing of bone crest in that side. So we proceed with the same technique, with the same protocol. We prove the allograft block. We fit perfectly this block. We screw the block, and it's perfectly fixed to the defect. We put L-PRF membrane on top, and on top of this L-PRF L-PRF membranes, these collagen membranes that are very perfectly also and tight, perfectly fixed with these titanium pins. On top of this collagen membrane, we use also this L-PRF. We have to release the flap, and finally, we close everything in a simple way, in a passive healing, in a primary bone healing, the totally time for the healing we use. This is the OPG after the surgery, and 6 months afterwards, 7 months afterwards, we go for the implant installation, and clearly you can see here how nice bone we can appreciate now in this right side of the mandible. We lift the flap. Well, before we compare, we analyze the quantity of bone that we could augment with this, in my opinion, very easy technology. In the front area, the same. We can compare before on the left side and after on the right side of your screen, and clearly we can see that we have some millimeters to install several implants, as you are going to see immediately. And another clinical aspect is the difference that you can observe before and after. Here the palate is totally flat. However, in the right side, after the healing of this graft, we can see some vertical palate here. This is because we have more bone in a vertical direction and also in the horizontal direction. We proceed again, the same we did before. The difference here is that we have to do the horizontal incision a little bit in the palatal side to have a keratinized tissue in the vestibular aspect of the crest, of the implants. We eliminate, take out these screws. You can see that there is no resorption. Almost no resorption. Here, again, we use the surgical stent, and according to the surgical stent, we install the 3 implants, number 13, 15, and 16. These are the implants on the left installed and the definitive abutment on the right side. Again, the one-time, one abutment approach. We cover everything principally and particularly in between the implants, because the flap is not going to be able to reach the palatal lip of the incision. We suture everything, considering that we are going to have here a secondary intention healing. However, we have L-PRF behind or on top of the bone. This is 3 weeks afterwards, where clearly we can see the healing of these implants and the mucosa, where we can observe a keratinized mucosa on the vestibular aspect. The provisional prosthesis 1.5 years ago, more or less, in January 2020, the smile of the patient. And what I want you to pay attention to the maturation along the time of this kind of bone. You can see here the trabeculas clearly, and we are going to have some resorption in the last implant, but this resorption in this distal aspect is because the recession of the tissue in that zone. As you are going to see clearly, we see the keratinized mucosa on the vestibular aspect. This is number 13, number 15, and number 16. In September 2020, with the definitive prosthesis finished, and we can see here perfectly the adaptation and the maturation and the remodeling of the bone, of the graft. And I'm immediately going to show you the comparison with the implants immediately installed with this remodeling image. The smile of the patient. You can see here the final X-rays, the last X-rays. And look in January 2020, and 1 year later, where we are obtaining here a clear remodeling of this graph that we have used. Not only remodeling, but also we can see some corticalization on top of this crest. Clearly, the treatment was a success, and done what is more important in an easy way for the patient and in a painful way, and we don't have to use, as you can see here, so sophisticated technologies that sometimes we use them. This is the CBCT scan 1 year later, where you can see clearly the quality of the bone all around the implants. And the last case I'm going to show you very fast is also a more demanding case, because the situations and the technologies has to be applied in the different clinical indication, as we are showing in this corporate forum. And we see in the right side of the patient, the left side of the screen, the problem that the patient has clearly in the vertical dimension here. So we proceed with the diagnosis, the analysis of the CBCT scan, and again, the same procedure, where we go for a digitally designed allograft block that is very well designed. This is very important. We proceed with the surgery. We made the incisions, and very important in the lower jaw, as you can imagine, is to prepare perfectly the flaps, and probably the soft tissue has to be prepared before the implant, the graft installation. We have to clean perfectly the surface of the bone to eliminate, to take out the whole soft tissue. We have to to be aware and to take care of this, as you can understand, these nerves, and also in the lingual aspect, the muscles and also the arteries, where we have to prepare perfectly and very gently this soft tissue. But at the end, it's very important to obtain the elongation of this flap to cover the whole block that in a particular, in the vertical aspect, we are going to increase the bone of the patient. This is the block previously designed, the fit of and the fix, how we fix the bone allograft, the L-PRF on top, the collagen membrane on top, and also more L-PRF membrane. And finally, we go for the suture, again, without tension, to obtain a primary bone healing. This is the OPG immediately after the surgery, where we can see perfectly the bone block there. And after 6-7 months, we proceed for the implant installation. We take out those screws, osteosynthesis screws. We install the implants in the normal way, in an easy way, and we have keratinized tissue in the vestibular and also in the lingual aspect with suture. And finally, we go for the provisional prosthesis. And then again, you can see here the trabecular aspect of these allograft blocks, but you will see clearly how these blocks are remodeling. This is some months later on. And this is before, with the prosthesis immediately installed, and this is 6 months or 5 months later on, where we clearly see in this image how these allografts are being remodeling. And this is, in my opinion, a very important aspect. And we still don't know if this comes from the L-PRF membranes, but for sure that the L-PRF membranes is going to help us in soft tissue healing. That is clear. So this is the CBCT scan of this case, of this lower right side. And what about the literature in these techniques using allograft blocks? As you can see here in this systematic review coming from last year, there is no differences in implant treatment outcome after at least horizontal ridge augmentation with these technology blocks compared with autogenous block. And in addition, we know that when we use L-PRF membranes for covering autologous bone grafts, the results are going to be even better. So clearly, dear colleagues, the conclusions are very, very sharp. The first conclusion that I can tell you with this technology is that the combination of biomaterials and L-PRF can accelerate healing in time of implant insertion in sinus lift procedure. Second is that L-PRF membranes can be an option to close perforation of the sinus membrane. Clear again, and of course, we are going to use less biomaterial and less collagen membranes. This is an important issue again. And finally, although there is no literature still with these digitally designed allograft blocks, but having the previous allograft blocks literature, as I have just said with this systematic review, we can anticipate that this technology is going to work. And in addition, the added value of the L-PRF, for sure, that has to be demonstrated in the very near future. Thank you very much for your kind attention.
Thank you very much, Juan, for this excellent presentation. So we can follow our program with our next speaker. I'll ask Professor Marc Quirynen to come to the podium again to give his second presentation on guided bone regeneration. Marc, the floor is yours. Thank you.
Thank you. Dear moderator, dear colleagues and friends, in this presentation I would like to talk about the L-PRF bone block. And here you see immediately the step-by-step procedure. First of all, we will start with a crestal incision to prepare a full thickness flap, and also, if needed, some very small releasing incisions. Then, when we have prepared the full thickness flap, we have to remove, like Juan also was pointing to, all the remnants of periosteum and connective tissue that might be still on the recipient bone. And then we are trying to prepare a number of small perforations to make sure that we have enough blood supply for the graft. The next step is then to pin, first of all, a collagen membrane, and on top of this, 1 or 2 L-PRF membranes, and you will understand why later. Then we apply the L-PRF bone block. It might be important for you already to know at this stage that you should try to overfill around 15 to 20%, because at the end of the day we saw that we will have a resorption during the healing time of around 15%. In the next step, we will fixate the collagen membrane and the L-PRF membranes on the palatal side. We have to immobilize the flap. And then we will suture, and we will try to go for a suture, a healing via primary intention. Now it's the pleasure to show you my first case, in which, unfortunately, I made several mistakes. That might be nice to see at least my mistakes. In this patient, there was a trauma on the central incisor, and there were quite deep pockets on the palatal side. And the panoramic view of this patient, but the actual slices, as you can see here, clearly show the degree of bone loss around this central, but also around the lateral incisor. And this all due to a longitudinal fracture of the root of the central incisor. And here you can see the consecutive cross-sectional images for the lateral incisor and the central incisor, with a huge amount of bone loss. And here you see, after raising the flap, the defect, and after extracting the central incisor. And unfortunately, I was asking myself, how will this area heal? Because at the end, we only have this very tiny buccal bone, which probably represents the entire bundle bone, and we know of the bundle bone that it will disappear after tooth extraction. So, dear friends at home, how would you approach this defect? What would you do? Well, honestly, I didn't know what to do, so I decided to see what the result could be of an L-PRF bone block, which I have prepared, like already discussed previously. We applied it in the defect, sealed it with L-PRF membranes, tried to have a nice closure, but as you can see, we were not really very successful, and this is the opening that remained. Of course, I have to admit that this is a quite well-contained defect, but the mistakes that I made is I've forgotten to place these extra perforations. I did not use a collagen membrane. I also did not fix or pin these L-PRF membranes. And I was not able to approximate the two flaps. Here you can see the healing after 1 week, after 1 month, and after 5 months, with a very nice healing so far. And after 7 months, we decided to take another cone beam. Here you see the cone beam before, at the moment of guided bone regeneration, at the moment of applying the L-PRF bone block. And as you can see here, there are many of open areas, and these open areas do represent the chopped L-PRF membrane pieces. And this is the result after 8 months of healing. And what do you think? Isn't this a beautiful healing? Along this lateral incisor, even without an endodontic treatment. But what happens around the central incisor? You see the huge defect. The small amount of bone remaining after extracting the tooth, and, believe it or not, the healing after 8 months. A perfect healing of this bone. And if you overlap the two situations, before and after, and you look to what happened over time, you see that we indeed have lost a little bit of the buccal bone, but nearly nothing in the vertical direction. And here you see the two situations immediately after the application of the L-PRF bone block and after the healing, 8 months of healing, nicely synchronized next to each other. And I think these images clearly show the beautiful amount of bone that could be regenerated in a very easy way. Also very comfortable for the patient because we didn't need a donor site. Here at the moment of re-entry with a nice alveolar crest. And here we are taking a biopsy really true and true from the labial side to the palatal side. As you can see, a really nice piece. I think, to be honest, a little bit too thick. We were able to insert the implant in a prosthetically driven position. Here you can even see where we took the biopsy, in this area. This is 4 months after implant insertion. 1 year of loading. and a cone beam CT after 3 years of loading. And look to the beautiful bone condition around this implant, and also to the quality of the bone. The biopsy here, going from the labial to the palatal site over a total distance of 10 millimeters, with bone formation over the entire area. And keep in mind, in this area, there was basically no bone. Under higher magnification, the labial side, the mid side, and the palatal side, the newly formed bone in dark blue or in red, the connective tissue with the dense collagen, and the bone substitute in light blue. I think this is really a beautiful healing. Now you see again the cone beam CT consecutive cross-sectional images at the moment of guided bone regeneration, after 8 months of healing, and now after 3 years of healing, with an extremely nice result, I think. But I might be biased, of course. I think you have to decide yourself. The position of the central incisor after 8 months and 3 years later, with more than enough space around and bone around this implant. The only shortcoming I think you can discuss about is this area here, where there is not really a good connection between the recipient bone, the bone of the patient, and the augmented or regenerated bone. And this might be explained because of the lack of perforations of the recipient bone. A short video to illustrate the therapy. In this patient, a tooth was extracted. There was no L-PRF applied. We have waited for the soft tissue healing. That was the moment we saw the patient. Now you can see the incision with a very small releasing incision in this area. The preparation of a foot thickness flap. I think you can immediately see the huge defect that we have. We are going for an immediate implant placement, preparing the osteotomy. The perforations of the recipient bone, the application of the implant, of the collagen membrane, first on the buccal side, later on the palatal side. The L-PRF bone block. Remember, you have to over-augment, as I told you, between 15 and 20% of over-contouring. The release of the periosteum, or the incision of the periosteum, to be able to have a coronal advancement of the buccal flap. The application of L-PRF membranes and the suturing. Here you see another case, quite similar, with a huge defect at the moment of implant placement. Again, we are using an L-PRF bone block, as you can see here and here, covered with a collagen membrane, and on top of this, L-PRF membranes. Here you have the situation 7 days after the application of the L-PRF bone block. The healing after 2 weeks, with a small opening where the two flaps are approaching each other. But we didn't do anything, and this is the nice thing with these L-PRF membranes covering a collagen membrane, like was also presented by Juan. The soft tissues can nicely grow over these membranes. And you don't have to remove the graft at all. The healing after 2 weeks and after 6 weeks. And then a new cone beam 5 months after the surgery. And I think you can see a beautiful buccal bone, which also, if you compare from here to here, increases significantly in radio opacity. And dear colleagues, this can only be explained by bone formation. And then the clinical situation later on. The intraoral X-ray at the moment of implant loading. 1.5 years later and 4 years later. Again, showing you a very nice healing of the bone without any bone loss around the implants. A similar situation. The organizers did ask me to speed up a little bit. That's why I'm jumping fast from one slide to the other. The application of the collagen membrane, and on top of this, the L-PRF membrane. This is at the moment of abutment connection. And here you see the same implant now after 4 months of loading with, again, a nice buccal bone. X-ray after 4 months, after 2 years of loading, and after 4.5 years of loading. And again, with a very nice and stable bone condition. And then we saw this patient. It's a bit similar, Juan, to your case. When we took a cone beam, with the axial slices and the consecutive cross-sectional images, a clear confirmation of a very narrow jaw. This patient went to another colleague, and this colleague gave to this lady the option taking bone blocks, either from the iliac crest or from the skull. I mean, for me, it would not be that difficult, but for this lady, this was, from an aesthetic point of view, not really appreciated. Or intraorally, from the chin and the ramus. But the patient didn't like these very complicated interventions. So we were allowed to place an L-PRF bone block, which you can follow in this short video. It's basically always the same procedure, full thickness flap. Make sure that you can reach the entire area. I think you can understand how narrow this alveolar crest is. Now we have to remove all the remaining connective tissue. You can either use a Rhodes or a burr. I prefer the burr. And now we are starting to make a lot of small perforations in the buccal border of the bone of the patient, and this to have an optimal blood supply. The incision in the periosteum for the coronal advancement of the flap. Then the application of the collagen membrane. using either pins or screws, as you can see here. This intervention has been done by a second-year postgraduate student of our department, Simone Cortellini. And here you can see the L-PRF bone block. Perhaps he was a bit too ambitious here, because it's really a large bone block. You see that you still can modulate it a little bit inside, but still it has its form stability. And then we are going to fixate the collagen membrane on the palatal side. The next step will be to cover this area with L-PRF membranes, and then we can suture. Here you see the image after 3 days, and unfortunately the patient lost the sutures in this area. The situation after 7 days, with the opening in the flap after 14 days, but I already told you, don't be nervous about this. You don't have to do anything. You can ask a patient to rinse with a chlorhexidine, but keep in mind these L-PRF membranes have also an antibacterial capacity, so biofilm formation does not occur that fast. Now the patient was asking to wear her denture again, and we were telling ourselves, damn, how is she going to wear this denture? So we decided at that moment to place 3 narrow diameter implants, which will support the removable denture in the next 6 or 8 months. And you see also after 3 weeks the nice closure of this area. The situation after 2 months. And here you see 3 weeks after the application of the L-PRF bone block. In red, the outer border of the bone of the patient. And this, dear colleagues, dear friends, this is the healing after 6 months. And as you can see, the black areas are nearly all filled with white material, and this can only be explained by bone formation. And also the radio-opacity increased over time. And also this is a proof of bone formation. This is at the other side, with, again, a beautiful healing. And here you can see, even in the second quadrant, we even were a little bit ambitious to think about a vertical augmentation. But if you look to the healing afterwards, indeed, we could obtain a beautiful healing also in the vertical direction. So we were able to place the number of implants that we promised the patient, and on top of this, a removable bridge has been prepared. And here, a quite similar situation, and a patient who lost her one remaining canine, still having only her 2 molars. Again, a relatively small alveolar crest. The therapy, the same as in previous case. Now we have immediately placed 2 narrow diameter implants to support the prosthesis. The application of the L-PRF block, the collagen membrane. On top of this, the L-PRF membranes. Suturing, healing after 3 days, 1 week, 3 weeks, and 7 months. And you can see that the patient indeed has been wearing her denture. And what was the result from a radiographical point of view? The situation at the day or 3 weeks after the application of the L-PRF bone block, and this is after 6 months. And look, for example, here we guess that this space here is filled up with a large piece of L-PRF membrane. That's also the reason why I told you, do not forget to try to get small pieces of the L-PRF membrane, a nice homogeneous mixture. And here you see that this area has been filled up with bone, and also, again, you see a nice increase in radio-opacity. In the center, and then in the second quadrant. I have to skip this one. And here you see a picture at the day of re-entry. I mean a video, sorry. Keep in mind, here we had a very narrow crest. When we are using the RODAS, we were not even able to retrieve some bone substitute. And here you can see how difficult it was to really start our osteotomy, clearly showing the density of the bone and the application of the implants. Again, this patient was asking for a removable bridge, which we could easily support with these 6 implants. The most important question, dear colleagues, is, has this been proven by clinical trials? Well, we have published in 2018 a first paper on the use of this L-PRF bone block, reporting on 9 patients and 14 sites. We have a cone beam before, during, and 6 to 8 months after the application of the bone block. And we did measurements at 2, 6, and 10 millimeters away from the crest. And we also performed some volumetric measurements to look to the evolution of this L-PRF bone block. And here, dear colleagues, you can find the data. The width of the alveolar crest, 2 millimeters away, 6 millimeters away from the top of the crest, and you can, before the application of the bone block, and you can see that in the number of sites, the width was less or equal to 2 millimeters. Higher up, it increased to 4 to 5 millimeters. As a mean, we had a width of the alveolar crest of 2.8 millimeters. After surgery, after the application of the bone block, we were able to bring it up to 8.7 millimeters. And this was quite well for all the situations. So we augmented with around nearly 6 millimeters. And here you can see the situation after 6 months of healing for the same sites and the same patients, as you can see here. And overall, after 6 months, we still have a width of 7.3 millimeters compared to the initial situation, an increase in width of 4.5 millimeters for nearly all the patients. If we then consider the 2D, two-dimensional changes in a percentage, you can see the degree of resorption. All sites resorbed, going from around 3% to one case reaching even 40%, with an overall mean of 16%. That is why we suggest you always to overbuild around 15 to 20%. This resorption especially occurred at the top of the crest and to a lower extent 6 millimeters away from the crest. And the resorption basically was confirmed via these volumetric measurements. At this moment, we are working on the second paper in which we have 29 patients and 36 sites, basically following the same protocol as I already have discussed. The patients have a mean age of 51 years. From all these 36 sites, only one graft failed, but in all the other ones, we were able to place our implants in a prosthetically driven position. And up to now, we have a 100% survival rate of these implants. And the mean linear alveolar ridge gain was 4.6%. That's why, dear colleagues and friends, I think that an L-PRF bone block can be very useful for a lateral bone regeneration. But you have to keep in mind there is still a little bit of resorption. That's why we advise you to overfill. From the few biopsies that we were already able to analyze, we could clearly see that there was less remaining bone substitute to what we were used of when we are not using the L-PRF bone block. I also, from my experience and from the experience of my postgrad students, have to tell you that this surgical approach is quite forgiving. Think about a wound dehiscence. As Juan was already telling us, the patient is the most important factor that we have to consider, and the acceptance ratio or the degree of acceptance of this type of treatment was really high by the patients, especially because of the low morbidity. This treatment has a high feasibility and a very high predictability for us as clinicians. And dear friends, if you would replace the bone substitute by grinded dentine, you can even go to a 100% autogenous treatment. Thank you for your attention.
Thank you very much. We are now going to have the next speaker. So now we are going to have Juan Blanco again, that is going to talk about soft tissue management utilizing L-PRF. Juan, the floor is yours.
Thank you very much, Gil, again. I saw you before, no? And again, it's a pleasure to be here to talk about soft tissue management. And again, it's an important topic for us as clinicians. And when we think about soft tissue management, immediately we are going to think in cases like the one you see in the screen. This is root coverage, for example, and also increase in thickness and width of keratinized tissue. But we cannot forget, as the whole day we are talking about the same variable. This is the patient. And for sure, a better healing and a better post-op in terms of less pain, less morbidity for our patient is, in my opinion, very, very important, and as clinicians should be mandatory. So I'm going to talk about first about root coverage with L-PRF. What does it mean, L-PRF for root coverage? And then this way to improve the healing in some indications. So the first paper, again, is a randomized clinical trial, the top in research, let's say. And in this case, this author has compared In 20 patients, he has treated 60 sites, 60 recessions, Miller class 1 or 2 with at least 3 millimeters of depth in a randomized split mouth design again with a 6 months of follow-up. And he has compared the coronally advanced flap plus connective tissue and the coronally advanced flap plus L-PRF membrane. So comparing the, trying to eliminate the use of connective tissue graft and different variables. The reception depth, the keratinized tissue width, probing depth, and very important also, the patient morbidity or patient discomfort measured by a visual analog scale score. So in this first study, we can see clearly that here there are no difference in terms of recession depth remaining, but also we can see here that there are some differences when we compare connective tissue versus L-PRF. And let's say that when we have to increase the keratinized tissue or when we have very soft tissue, it's very important to use something else than the L-PRF, and in this case, the connective tissue graft. Also, there was no difference in terms of root coverage percentage and completely root coverage. So another important aspect, as I have just said, are the PROM variables, and in this case, clearly the base scores during the first post-operative week were significantly lower for the L-PRF group. So if we have everything in contest, probably if we use L-PRF, we are not going to obtain as much as keratinized tissue as when we use connective tissue. However, in cases where we don't need this amount of connective tissue, or sorry, the keratinized tissue, probably the indication should be better for the L-PRF because the patient discomfort, the patient morbidity is much less. Let's go for another paper. And in this paper, again, they compare the CAF technique. This is the coronally advanced flap plus connective tissue graft. And the test analysis is the connective tissue graft plus the coronally advanced flap plus connective tissue plus PRF injected in this connective tissue to check if this PRF means something in terms of the different variables. For example, the recession depth, where we can see clearly that there are statistically significant differences between the groups. Again, for the keratinized tissue width or height, and no difference in terms of gingival thickness, and no difference in terms of mean root coverage. However, we can see that the figures are better when we use PRF, and also when we talk about complete root coverage. So the conclusions, again, are very clear. The addition of PRF, although in an injection solution to the coronally advanced flap plus connective tissue treatment, showed further development in terms of increasing the keratinized tissue height or width and decreasing the reception depth. So these two papers clearly show us that the L-PRF means something in soft tissue coverage. And if we go to this systematic review in that was published last year, comparing these different technologies by an important group, as you can see and you can read in the authors, the coronally advanced flap has been compared to the coronally advanced flap plus PRF, the connective tissue with CAF versus CAF plus PRF, and so on, that at the end we could summarize this systematic review with this meta-analysis that when we compare CAF versus CAF plus PRF in root coverage, we can see that although there is no significant difference between both groups, it's very close to the significance, is in favor of the PRF. However, when we compare connective tissue graft versus PRF under this or beneath this coronally advanced flap, the results are a little bit better for the connective tissue graft. And for the keratinized tissue width is almost the same, and when we talk about clinical attachment level is almost the same. So if we summarize in this table, what should we choose when we are going to do a procedure for root coverage? Probably the best treatment is the use of a CAF plus connective tissue graft plus on top PRF, at least for root coverage, clinical attachment level, and probably also for keratinized tissue width. So we have to keep in mind that clearly in this evidence is clearly showed that this L-PRF or PRF is an important thing to be used with our patient. It has clearly an important added value. So let's see different clinical cases for root coverage. This is the first case on the right side of the patient where we have to prepare beforehand the non-cervical carious lesions in every of the tooth, as you can see here before and here after on the right of the screen. This is before and this is after preparing the two sides, treating these non-cervical carious lesions. And according to the coronally advanced flap technique published by Giovanni Zucchelli, Massimo De Santis in 2000, we can proceed with this technique to this right side of the mouth, and clearly we try to reproduce the design of the coronally advanced flap as has been published. We leave the flap in a full split incision. As you all know, we have to go for the root planning. We have to prepare the roots. We have to epithelialize the anatomical papilla of every papilla. We go for a connective tissue, a small connective tissue to be suture only on the canine because the quantity of keratinized tissue was smaller than in the other sites. And after doing this, we go with L-PRF membranes beneath the flap and on top of this part of the connective tissue. We go with one layer that we suture on the mesial aspect of the flap and also on the distal aspect of this flap. As you can see clearly here, the distal suture and the mesial suture. We go also for a second layer for this procedure of L-PRF on top of the previous one. We place very gently this L-PRF membrane on top of the other one and beneath the flap. And this is once we advance the flap and we go for the sling sutures from the distal aspect to the mesial aspect. This is 1 week later, and this is some weeks later. You can see the smile of the patient now where we can appreciate clearly the thickness of this zone, and all the root surfaces are 100% covered. We go, this is before, this is after, and we go also for the left side. You can see here the Miller class 1 recession that is perfectly covered, but in this case without connective tissue, just coronally advanced flap plus L-PRF membranes. This is in the upper slide, the previous, the posterior aspect, and this is 1 year post-treatment, where clearly we can see the success of the treatment with a 100% covering in the right and also the left side. Let's see another case, probably even a more demanding case, because there are a very thin phenotype where we can see perfectly the undercuts in between those roots. The roots are very, very prominent, as you can see, and probably the phenotype is so thin that clearly the patient can have some bone dehiscencies or fenestrations in some places. We go according to also, again, this paper some years later by the same authors, 2007, and this is how they explain the procedure, the full split technique, preparing the surgical papillas and also the anatomical papillas, and according to this procedure we do the surgery. We deepithelialize the anatomical papilla, we tunnelize the front papilla in a split designed flap. We go for the connective tissue in the palatal side, and in these cases we always also use the L-PRF behind or beneath this trump. We close everything, and then we proceed for the insertion of the connective tissue just in the front area where the phenotype was thinner with respect to the other sides. So we suture to the periosteum of the surgical papilla that we have prepared beforehand. We tunnel this connective tissue, and we suture also the connective tissue on the other side of the left, and the distal aspect of the left central incisor. We go again with the same technique, with a double layer of L-PRF membranes in the whole places, in the right and in the left side, and finally we proceed for the coronally advanced flap and the suture of the zone with the sling suture. This is the result. Some weeks later, this is the before, this is the after, with the 100% of coverage of the recessions. But what is more important, not only here where the connective tissue has been applied, but also in the posterior areas, the undercuts have disappeared. So an important aspect also for our patient is not only to go with the root coverage, but also with the change of the phenotype. And this is a 6 months follow-up slide. And another option is, as I have just told you, is the use of this technology to avoid or to reduce the pain for the patients when we are going to use these free gingival grafts. Because when we harvest a graft from the palate, usually we sometimes leave a bone open that has to heal in a secondary intention. So according to this randomized clinical trial, where they compare PRF plus a glue, this is cyanoacrylate, compare with cyanoacrylate alone or with compression with a get gauche. And they have analyzed the different aspects in terms of patient-related outcomes, let's say morbidity, pain, swelling, inflammation, and so on. And the results, as you can see here in this graph, are very clear. The less pain, the less inflammation, and the less everything is for the PRF group. So bleeding, pain, epithelialization, feeding habits and sensation scores, and those prone variables are significantly lower when we use a PRF membrane. So, dear colleagues, in these palatal wounds, the PRF is clearly indicated. So cases like this, for example, a patient that is going to be treated with an implant here, and she has problems with the mucosa, where we have to make a split thickness flap and to suture the flap in a coronal direction. Then we are going to obtain a free gingival graft from here with the same shape as the bone we are preparing the vestibular aspect. This is the suture of the flap, the split thickness flap. You can see clearly the bone, and according to this shape and size of this bone, we have to go to the palatal mucosa and to extract the same size and shape of this free gingival graft. We go for it, we suture this free gingival graft to increase the keratinized tissue of this vestibular aspect of this molar. And finally, in the palatal area, we suture one or two L-PRF membranes. That probably is one that is folded. And clearly, again, you can see that it's possible to suture this kind of membrane, the tensure that we can apply to these membranes as high as they allow us to suture this kind of material. This is 7 days post-op, and you see how the palatal is healing, the epithelium is growing, and here is a substance that is clearly representing the healing of this wound. And clearly this is going to heal perfectly some months later on and allow us to put the implant in the right way as we were expecting beforehand. And another clinical situation is in this female, 25 years old, a patient with a cleft lip, also with problems and a cleft palate. As you can see here, that this patient has been treated some years ago with bone graft, as you can see in this OPG with this screw that is fixing an autograft block. And the treatment planning is to modify the problem that the patient has on the vestibular aspect with a free gingival graft to remove or take out this screw, and also to do ortho treatment. We proceed with the same technique as the previous case. We go for a split thickness flap that is going to be sutured in the apical part of the vestibulum to increase the size of the vestibulum and also to allow the mobility of the lip. We take out this screw, and exactly in the same way as we did before, we extract these grafts, free gingival grafts, that are going to be installed in the vestibular aspect. However, before going there, we have to suture here these L-PRF membranes. And this is healing. We prepare the grafts, we suture this graft, and clearly the height of the vestibulum and the change in the quality of the mucosa is going to change. You see before and after pre-surgery and post-surgery, and clearly the depth of the vestibulum is increasing. And before and after where the problem for the mobility of the lips was one of the main complaints of this patient. And finally, we also eliminate or take out this screw. We go on with the ortho treatment. The palatal side, the palatal mucosa has healed perfectly. This is the X-rays without the screw, and after finishing the ortho treatment, and this is the result in the papilla, as you can see between the 21 and the 22 teeth, where everything is well treated and with success for this patient. And last indication is also that L-PRF can be used for soft tissue healing, as we were saying the whole session. And in this case, where we are going to augment and to increase the horizontal aspect of the lateral and this left side of the lower jaw, we have to take the advantage that on the same surgery, we can increase the thickness of the mucosa and also the quantity of gingiva, let's say the keratinized tissue. We go for the treatment of the posterior zone of this lower left side of the mandible. We go, as I told you in the lecture before, we go for the allograft block. We cover everything, also with a collagen membrane. On top of the collagen membrane, we go for this L-PRF again, but here you can see a double layer of L-PRF membranes on top of the roots of those teeth. You clearly see the front view, the vestibular aspect with the two membranes on top, and everything is closed with a coronally advanced flap. At the same time, we go for the advancement of the flap to cover the augmentation technique. This is 6 months afterwards where we install the implants. This is the healing. This is the CBCT scan. I'm going to be a little faster with these images, before and after. And what is more important in this lecture is that look at how nice is the soft tissue, the thickness, and also the height of the keratinized tissue around the implants. But again, compare the before and after of the soft tissue, how it heals perfectly, how they look, the phenotype is thicker. We can increase also the height of the height and thickness of the gingiva of the keratinized mucosa. So probably the L-PRF is going to add something when we use in this management of soft tissue, and probably the best choice is to use both connective tissue and L-PRF. But why not using some acellular dermal matrices with L-PRF too? Both technologies together probably are going to improve even the results, not probably better than the connective tissue, but probably very close to the results that we can obtain when we use connective tissue plus L-PRF. So the conclusions, again, like taking a home message is, first, for root coverage, for sure that coronally advanced flap plus L-PRF is better than Cafalon. For increased keratinized tissue we need connective tissue. For root coverage and probably for connective tissue width to increase, probably it's better to use both technologies. And the L-PRF clearly means, dear colleagues, less post-operative discomfort and a better healing. So let me finish with this, Mr. Chairman, slide that I think summarizes when something new appears, like a new technology, a new surgery, or whatever. It's clear that we need randomized clinical trials, that we need long-term success. But read this, please. Every revolutionary idea seems to evoke 3 stages of reaction. They may be summed up by the phrases. First, we answer, well, it's completely impossible to use this technique or that technique. Second, after some years, we can say, well, it's possible, but it's not worth doing because what I'm doing is more or less the same that this new technology. But when everything is already published and already demonstrated, what we say? I said it was a good idea all along. And I have treated my patients long time ago with that technology. Thank you very much.
Thank you very much, Juan. We are now going to switch to the next speaker. And the next speaker is going to be, again, our good friend Marc, who's going to talk about guided to regeneration. Marc, thank you very much. The floor is yours.
Dear Mr. Chairman, it will be a short presentation, and it will be about the use of L-PRF in the treatment of intra-bony craters around teeth. Here you see a patient who definitely has a problem, a periodontal problem, here in between the central incisors, around this lateral incisor and this first molar. And during open flap debridement, we have used L-PRF to fill up these intra-bony defects. And here you can see the healing after 3 months, with a beautiful regeneration of the bone in these areas. Which protocol are we following, step by step? 1 week prior to the treatment, we will try to disinfect the oral cavity as much as possible, and definitely the sites that need a guided tissue regeneration locally with either a high concentration of chlorhexidine or a local antibiotic. Then we will, of course, remove the pocket epithelium and the granulation tissue. We conduct a perfect root planing. And now we will do an important step again. We will rinse the defect with the L-PRF exudate. Please remember, the exudate has antibacterial capacity and also contains a lot of growth factors. Then we will prepare some small perforations to have an optimal blood supply. And then we will apply the L-PRF. And what we are going to use in the defects is the face part, the part that contains the high concentration of leukocytes and platelets, the face part of the membrane. And then we will seal the defect with 1 or 2 L-PRF membranes. And we suture again for a healing by primary intention. The treatment is summarized in this video. I think you can clearly see this huge defect mesially to the second premolar. We are at the beginning of the surgery, again, disinfecting this area with the chlorhexidine solution, a 1 or 2% chlorhexidine solution. You see the huge defect, nearly 10 millimeters on the mesial side of the second premolar. The incision. Here it is, of course, very important to remove the pocket epithelium. To remove all the granulation tissue, which you can see here. Also using a small bone curette on both sides. And you see the huge amount of granulation tissue that we were able to remove. Now we are doing a root planing, first with the ultrasonics and afterwards with the hand instruments. Here are the L-PRF membranes again. We collect the L-PRF exudate. Remember, this is the liquid leaking out of the clots when they are getting compressed into the membranes. And then we decided to cut away the face part of the membranes. The face part, as I already told you several times, which is containing the highest concentration of leukocytes and platelets. And we will chop these in small pieces in order to have a perfect fit within the infrabony crater. Removing the excess exudate. Some measurements to report the healing afterwards. And this might be also a very useful trick because at the end of the day we would like to seal the defect with L-PRF membranes. So here we are trying to estimate how much width and length that we need. And in order to fit well in the interdental area, in the proximal area, we use this instrument to create on both sides space for the roots. In order to have the best fit interdentally. Now we are rinsing the infrabony crater with this L-PRF exudate. And we can even keep it there for 1 or 2 minutes to give the time for the antibacterial effect. And now we are filling the defect with the chopped L-PRF face part of the membrane. Try to remove the excess exudate. And dear friends, please keep in mind, 100% autogenous and not expensive for the patient. So you can use this technique at several interdental areas or for several infrabony craters when you do a flap over several teeth. And now we will apply the L-PRF membrane. In order to seal the infrabony defect. And then suture. Is there any clinical support for this treatment? Well, if you look into the literature, you will find a variety of protocols. And when you look to papers that are published on the additional effect of applying L-PRF during open flap debridement, we were able to identify 3 different strategies, with the open flap debridement as a control, either to simply cover the defect, or to fill the defect, or to fill and cover the defect. So these are the three different strategies that I could find in the literature. And believe it or not, for all these three applications, there are already a number of publications with the authors positioned here. It are all RCTs comparing open flap debridement on one side versus the use of L-PRF during open flap debridement on the other side. Just covering the defect, as you see in this picture, you can see that if you combine open flap debridement with L-PRF, simply covering the defect, you get additional, statistically significant additional improvements in probing depth reduction, in clinical attachment gain, or intra-bony defect reduction. Here you see the second option, where the defect has been filled with chopped L-PRF membranes. You see a large number of papers, all of them, again, RCTs, and all of them show clear benefits, except this paper, published in 2019, where open flap debridement was not used, but a modified mist technique. And when you were comparing a modified mist with open flap debridement with the use of L-PRF, they were not able to see significant differences. And here you see the treatment filling and covering the defect, and again, a number of papers, all of them RCTs, and all of them showing a nice additional benefit when applying L-PRF. Then there is another strategy that you could follow. It's an open flap debridement using a bone substitute, or an open flap debridement using L-PRF, looking to whether L-PRF can reach the same benefits as when you would use a bone substitute. And here only one strategy has been used. On one side, open flap debridement with the application of a bone substitute, and on the other side, the application of L-PRF in the defect only. And here you can see the different papers. Again, all RCTs with, to be honest, a mixed general observation. Most of the papers were not able to show any statistical difference between either the use of a bone substitute or the use of the L-PRF. And two papers were negative for the use of the L-PRF. It's perhaps not well expressed. They saw, or they reported, some statistically better results when using a bone substitute. So this situation here, this condition here, is not well completed, studied, and is still open for discussion. What should we think about this? Well, here you have, again, Juan, nearly the same list of authors comparing or looking in a systematic way and with a meta-analysis whether L-PRF could be useful in the treatment of infrabony craters, published this year, with different treatment strategies, but to make the story more simple, here you see the forest plots. The first is comparing open flap debridement alone or open flap debridement plus the use of PRF. And here you see a clear statistically significant difference with an additional reduction in the probing depth of 1.3 millimeters in favor of the use of L-PRF. Here is a comparison between, on one hand, a bone graft, or on the other hand, a L-PRF. And you see here that there was basically no difference when comparing or including these studies. And here at the bottom, you can see whether the use of a bone graft without or with the addition of PRF could show any difference. And here you can see that when you add L-PRF to a bone graft, that you can have a significantly better outcome compared to a bone graft alone. And that is basically also what they concluded in their systematic review. The use of PRF in conjunction with open flap debridement statistically significantly improved probing depth, clinical attachment level, and bone fill, yielding to comparable outcomes when you do an open flap debridement using a bone graft. And then the combination of PRF with the bone graft or small biomolecules may offer certain clinical advantages. And that is why I think that L-PRF can also play a significant role in the healing of infrabony defects around teeth. But I have to be honest with you, our own experience with this treatment strategy or with the use of L-PRF in infrabony pockets or defects is little. But I think we can conclude from the literature at least that you can expect additional improvements, that the treatment seems to be have a high predictability and feasibility. We are working again with the 100% autogenous concept. I think there is, in my mind at least, sufficient scientific proof. And again, it's a simple technique and not expensive at all for the patient. Thank you, dear colleagues, for your attention. Sorry, Mr. Chairman, to be too fast.
No, thank you. Thank you, Marc. Thank you very much. So now we move to our last speaker.
Hello.
Nelson, thank you very much for staying with us. And you're now going to talk to us about biomimetics with the use of L-PRF. So the floor is yours, and thank you very much.
Thank you, Jill. It's been a wonderful evening for you guys, a wonderful morning for me. And I think it's great to hear all these great speakers and all the experience and all the research that has been done about L-PRF. I'm really happy to see this and to see, and at least I think we can see a better future for L-PRF, and it should have the right position in the armamentarium that we have to treat our patients and to get all the benefit for our patients. So I think for me, I'm really happy to be part of this great group that is working in this area. So now we're going to talk about a topic that I really like, and it shows maybe the purpose, and I'm glad to be at the end. It's not to show anything that I'm really trying to promote to use it, but it shows maybe what we can do in the future. It shows maybe what is the potential that we still not know about L-PRF, and why, I mean, we should keep on this path and using it as much as possible. So when we talk about natural guide regeneration with L-PRF, and we talk about L-PRF as a human living tissue, we are getting close to about biomimetics, of how we can replicate, how we can go for really regenerate tissue, really get too close to nature as much as possible. And I'm going to show you, I want to share with you this case just to start into the topic. And one of the most difficult things to do is to get full regeneration of some of the tissues. So as Juan said very well, sometimes it seems impossible, to replace, traditional techniques. But in this case, we are going to replace completely a skin graft by L-PRF graft to get maybe the same results, but in this case, we can see in the following pictures, we will get a better result than the traditional techniques. So after 6 weeks, we can see how we are transforming and getting, this area where there was no skin before because there was a malignant lesion that has to be extracted, it was resected. Now, after 6 weeks, we start to see a completely new regeneration of the skin in that area. And we can see the line of the incision, the previous incision, and no difference between the transition, the old skin and the new skin. So this is fully regeneration. And this is fully how we can biomimetic, the nature. So that's why we talk today that we try to go as much as possible for autologous products and try to be as much as possible a way of, foreign body reactions from different biomaterials that, of course, they are very biocompatible, but we are trying we are in the transition and how we get as much as possible of autologous products and get the best combination with the biomaterial that we have available. We are not saying, and I always say that L-PRF is not replacing or excluding or is the end for biomaterial. No, we have to learn how to use it, how to combine it, and we have seen it very well during the presentation this afternoon. So we know that the application of L-PRF, and when we talk about implant, that is one of the main topics today, is we know that if we apply L-PRF in the implant osteotomy side, we can improve the stability or can reduce, the loss of stability of the implant, and we can enhance the process of osseo integration. Also, we know that if we cover the implant, if we put L-PRF in the side that with the bone is the not very good quality, also we can improve, we can reduce the healing period, or we can improve, or we can speed up the healing and the osseointegration process. And we would try to, do biomimetic coating on implant that is maybe isn't a good alternative for the future, but still experimental way. We can also create some improvement of the soft tissues and the hard tissue around our implant. So that's something that we are also, or some people are working on. But we have already one of the best coating that we can use on our implant is L-PRF. And also we can use it like a L-PRF liquid form, the liquid fibrinogen that is not actually an L-PRF. We have to use the right names, but it has been proved that this, can connect in a different way to the surface of a different type of implant. So L-PRF, we know that serves as a reservoir for bioactive molecules to support wound healing and bone regeneration. So the overall findings suggest that L-PRF induce cell proliferation, migration, addition, and differentiation along with possessing anti-inflammatory properties, further supporting his therapeutic potential in wound healing and in bone regeneration. So why not use it? If it's autologous, it's inexpensive, and also it gives you a lot of benefits. So why not to use it? Okay, so we can use it. We have seen it very well. I mean, wonderful presentation this afternoon about, how many applications can be improved, and of course implants, and why we know that the hydrophilicity and the properties of the surface that we can get on our implant also make a difference, and how close to biomimetic, how close to nature we get in our implant surfaces, maybe we will get better implants. And what if we get this synergy, this potential, making or put together, what we can make and what nature gave us through L-PRF. So the simple application of this material seems to provide faster osseointegration. So why not to use it? So to prove that, we have to go maybe to the extreme, and that's what I'm going to show you in a couple of seconds. We know, this is one of the first studies that showed that macrophages are very important on the production of BMP2. And we know by the studies that on L-PRF, we have BMP2, BMP7, BMP9, BMP4. Those are the main BMPs they play a key role on the bone formation. So this maybe, plus the knowledge that we have today about the anti-inflammatory activity of L-PRF and how it can shift the macrophage polarization from M1 towards M2, it leads us to maybe what we call the new model of osseointegration. And through the mechanism and through the role of putting macrophages are key actors in the process of osseointegration. And these are the first cells that get in contact with the implant surface. So M1 and 2 macrophages maybe play a key role in changing the paradigm of osseointegration driven by an L-PRF and biomimetic implant surface. So this is one I'm trying to show you, and it's not a technique that I'm promoting. I just show you that this has been a research for over 10 years now. And we have been trying to prove what happens if you get a situation like this, where it's very common. You lose the buccal bone and you have a big cavity. What about if you fill the cavity with L-PRF and then try to regenerate all that bone around the implant at the same time? So that should be possible only if we can increase the amount of bone that is forming on the surface of the implant and get more contact osteogenesis at the same time that we speed up the distal osteogenesis. So this, we know, the role of M1, M2 macrophages and why is the main difference, how they can react to the environment, and how M1 macrophages are on the side of inhibition and of cell proliferation, and M2 macrophages are on the side of cell proliferation and tissue repair. And we know that, how are the good functions and the most important function of these macrophages when healing. And they are the first cells maybe that get in contact with the implant surface, same as the fibrin. And those are the main components of the L-PRF. So this may lead to now propose a different way to see osseointegration through the mechanism of the activation of macrophages. So we can see also how important is the characteristic of our implant surfaces. So how we can get a synergy between these two, these cells and this implant surface. Well, this is a study, it's a Raman spectroscopy analysis of L-PRF membrane, and we can see the cell type differentiation over time and cell stage over time. So we can see there's no time. This is a very complex to try to explain this, but there's no time to show that. But this is how we can study the during 48 hours, how this amount of leukocytes that are present here, how these macrophages change over time in the membrane. So we did this study on dogs to see how the synergistic effect of L-PRF and a micro nanometer surface can modify the process of osseointegration. So this is what we call the floating implant. So implants that would not be in contact with bone, just surrounding by L-PRF. So we would see an interaction of L-PRF with the implant surface and the surrounding bone. So this is what we did, extraction of the tooth and the dogs, and then fill those socket with the L-PRF, and then just put the implant inside and just allow it to heal with different type of surfaces. And same as we have seen, we cover everything with the L-PRF membrane. And what we can see is different surfaces, just on the control side, just a blood clot, we can see that we will get fibrosis and probably no way to get osseointegration. And that's what we should expect if we do something like this, if we put this in just a regular cloth. But if we try with in a regular cloth with a biomimetic surface, then we get some kind of, we can see the bone formation on the surface of the implant, but not as much on the surrounding bone. So we can get some bone on the surface of the implant, but not a very good stabilization with the surrounding bone. Now, if this is a closer look, and now if we add, to the situation, now we add L-PRF with a acid edge surface or typical surface, now we get the surface to behave like a biomimetic. So we get some kind of bone formation on the surface and also in the surrounding bone. But if we mix this, we mix a biomimetic surface with L-PRF, we get a very nice bone formation and a very stable bone to get a very nice osseointegration. And we started with a bone that was not stable. So this is the study that was done in dogs, animal study. And this is a part of a project that is been running for more than 10 years now. And I have extended to 15 years, so it will end in 2023. But this is what would be the possibility to have an osseointegration of an implant without primary stability, without bone preparation, without initial bone contact, without primary soft tissue closure. It's just like dropping an implant in a bone cavity, fill it with L-PRF. Load the implant at 3 months and deliver the final crown 1 month later. So that seems impossible, of course, and that goes against everything we know about osseointegration. That's what I said, don't do this. I'm not trying to promote this, but this is the preliminary results after 10 years of following up this implant. And I have decided to extend this to, because of the nicest result that we have, to 15 years. This will probably be the last research that I will do in my academic career. So preliminary data shows after 10 years, we just lost 3 implants. So it's over 95, 98% of implant survival. And we have lost more patients than implant, and especially after the pandemic, we don't know how many implants, maybe we have lost. But that means that implants can survive. And this is how I can show you what will happen over time in a typical implant case in this situation. So this we will have this canine, a very difficult tooth to be replaced by implant, already has recession, has no buccal plate at all, so has to be extracted because of the root fracture. That means usually, the loss of bone on the buccal aspect. To recreate this ridge, we will have, to remodulate and gain all those tissues that have been lost. So we would see, already has a fistula. We will follow these 2 lines and the papilla in between and the line of the area of the recession to see what will happen over time. We will do the extraction. It's a big canine. It will do it as less traumatic as possible, just by pulling this implant with this instrument. And we can see it's a big root. And you can see already that is no buccal plate at all the way up to the apex of the implant, of the tooth, excuse me. So yeah, it's a very challenged case to be restored and with a good function and a good aesthetic. So very good cleaning of the socket, and also of the soft tissue. You have to extract all the epithelium that maybe has been formed inside. So very good cleaning, and then just fill everything with the L-PRF before putting the implant inside. That implant will not be screwed into the bone. It will be just pocket into the L-PRF that we will put there, and then we'll pack again more L-PRF around the implant. So after packing more and more, in this case, that's what we use. We need to use enough. You can see how the implant is moving, and as we push from the palatal side, it moves in one piece everything. So we have packed L-PRF from the buccal and from the palatal side and from the culsal side also. So and we have used in this case 12 membrane, and now we will suture. As I said before, where the bone is, we inject also the exudate, and we just watch everything with the exudate in this area, and the suture is holding the implant and the L-PRF at the same time. So what will happen over time, we will see here, we will follow, this is the baseline, how we started, how this appeared right after the extraction. After 3 days, we can see how the gingiva is attached to the L-PRF. We can predict where the gingiva will be in the following days. That's what it looks like after a few more days. After 8 weeks, we can see that if we superimpose the baseline, after 2 months, we can see that the implant is still there, and we have not lost soft tissue, and we don't know about the bone yet. But after 12 weeks, we can take another CBCT, and we can see there's a lot of explanation for this, and of course, they have no time now, but we have been doing this for more than 12 years now, so we have a lot of answer to the question that we had at the beginning, but there's no time to go for that, but maybe in another occasion. But we can see after 12 weeks that something happened here, and we have been adding and remodeling the bone around in the buccal aspect. We lose a little bit, but we gain a lot of bone on the surface, on the buccal aspect of the implant. So after 12 weeks, 3 months, we can go back and see what happened. That was the baseline. Now compared after 3 months, we still gaining. We haven't lose anything, and now we can go and place our provisional and see what we look like. So after putting the provisional, we see that we have very nice soft tissue, and we have very stable implant, also integrated. And what will happen later? Well, I really liked this crown. The patient didn't like it. He wanted to have a bigger crown, and he didn't want it to get covered that recession. So wanted to get a crown that it was more, or looks like more bigger. So we did a bigger crown, and this is the 3 years control. So this is the final crown after 3 years, and this is the CVCT after 3 years. So after 3 years, we can still see that good quality of bone on the surface of the implant. On the buccal aspect, there was nothing. And remember, this implant was completely loose when we put it in place. So on other cases, just to show you this day by day, what is going on. There is no primary closure. There is no, all the implants are connected to the buccal environment. So this goes against everything we know. And again, I'm repeating, I'm not proposing this as a technique. I just showing how there are many things that will still not be answered about osseointegration. So this is about 30 days. And again, it's exactly the same. 8 weeks, we can start to see a bone formation around the implant. So that was the baseline. And after 3 months, we can see that it's a lot of bone form around the implant. We can still see the cortical bone of the residual socket that was there. And we can see after 3 months, we can place our provisional crown. And this is the provisional place after 3 months. And final crown 1 month later. And this is the 5-year follow-up control. And we can see on the CBCT after 5 years that, you know, the bone is very stable. We maybe we cannot say that we don't have 1 millimeter of bone on the close to the apex, I mean, to the coronal aspect of the implant connection. It's difficult to see on a CBCT, but we can see clinically that after 7 years, implant is still there. Our patient is not taking good care of the hygiene, so we need to reinforce that. And we don't have any recession. We got very nice soft tissue around after 7 years, after 8 years. 8 years and a half, you know, the crown was broke. So means that it's been using, the patient is using this crown. We were able to take the crown out and see the tissue and the condition of the implant underneath the crown. And it's still beautiful, very nice. And we will do another crown. So this is the control after 9.5 years. And this is the 10-year control. And you can see that the patient is still not good with the hygiene, with the cleaning. And probably I'm more concerned about the adjacent teeth in the future than the implant itself. This is the 12-year control, and we can still see that the adjacent teeth maybe are not as good as the implant after 2 years in place. So now this implant is getting close to the 14 years. So that's what I have decided to keep this trial going on for another 3 more years to get all the patients up to 15 years and 12 years minimum follow-up for all the rest. So this is we're trying to explain why the synergy, and try to answer why if L-PRF would induce this bone formation, and would implant surface really make a difference, or would this difference may explain why the success of this floating implants and under these extreme conditions. So we know, that the interaction of fibrin and this macrophages and this leukocyte with the implant surface is extremely important at the beginning. So we did a study with almost 56 different brands, and we published one of our students, postgraduate students, Dr. Andrade, published this study based on the most typical surfaces and the most common one. So we published this just this year, and we can say that not every implant is born equal, not every surface is born equal. It doesn't mean that we are talking about bad or better implant. It's just different. I always say that we are not talking. This is not a fight of what is good, which is bad. This is how we can get the best of everything, or how we can get the best synergy between everything that we have. So from the evolution of implant, we have machine, acid blasted, robotic design of the implant surface and 3D printed surfaces. So this is kind of evolution, and we can see it also if we do this study with the liquid fibrinogen that is close, the most close thing that we can have to L-PRF. And we know from the literature how this may influence, the topography of the implant surface may influence osseointegration. Some of the factors are still unclear, but we know that maybe there is a difference. We know from previous study how L-PRF can modify the osseointegration. So that's why we did this study and try to understand how is the interaction and how important could be maybe the interaction of the different implant surfaces, we can see here. I'm just going to show you beautiful pictures of electron microscopy, but not going in detail because that is not the purpose of this presentation. It's just to try to show you that, you know, different implants react differently to the in the first hours to the fibrin and the macrophages. And we used to think that rough surfaces probably will have the most impact on bone fibrin attachment, but it's not that way. You know, roughness doesn't mean that you will have more fibrin or more strong attachment to the implant. So we can see here very rough surfaces doesn't really create a very good attachment to the fibrin. Also, in most of the cases, we can see that fibrin fibers go parallel to the implant surface, and really they don't attach to the implant surface. They surround the implant, and they really cover in a very thick layer, and someone very thin and others very thick, and especially on a machine implant, and there is almost no cover of the implant surface. So you can see maybe a clean surface. Here you can see very clear how the fibrin fibers that are formed go parallel to the surface of the implant and not really going toward the surface. So when you can start to see some difference, you know, when we have some bioactive surfaces, some biomimetic surfaces that really start to change the game, and now we start to see completely different configuration of the fibrin attachment to the implant surface, and we start to see more cells, and especially we see leukocytes, and for the first time we start to see some addition of in the fibrin fibers, you know, directly into the surface of the implant, not just parallel, you know, they go directly to the surface and really attach to the surface. So the new surfaces like 3D printed surfaces also modify that in a very nice way. And we can see here how the fibrin fibers are very strong, very well attached to the implant surface, and how the cells, especially macrophages, migrate towards the surface of the implant. And that's very, very nice to see. And these are beautiful pictures of 3D printed implant surfaces. And you can see also that the implant, the fibrin fibers are not just attached perpendicular to the surface of the implant, but they also attach between the different roughness of the implant surface configuration. So it's not just attached to the implant surface, also they are attached between their configuration. And this is a beautiful picture to show different fibrin fibers going across the implant surface. And this is what I call, maybe we are getting to the roots of osseointegration. This is how you can see a very nice attachment perpendicular to the surface of the implant. So the fibrin is really attached like roots into the surface of the implant. And that maybe it's make a huge difference on an implant in a challenge condition. We're not talking about an implant that is screwed very tight into the bone, good quality of bone, you know, very good stabilized, I don't know, 50, 60 newtons of insertion torque. No, we're talking about an implant that has a maybe 5 Newton of torque, or maybe an implant that is completely loose. Well, this fibrin attachment maybe will be the answer in those cases, or will add a benefit to use it, and also may explain why we should use it maybe all the time, even in a very regular implant insertion. So with this nice picture, I think I should finish. And for me, it took me many years to get a picture like this and to see how this beautiful, this is like a tree for me. This is like, you know, that's what I call it, the roots of osseointegration. So thank you very much once again for this opportunity to share this. And I just want to emphasize that what I just show you is something that trying to put more questions on the this afternoon that answers. So thank you very much, Mr. Sherman, and been a pleasure to be with you this afternoon. And once again, thank you to organizing committee, SEPA, and BioHorizons for getting all that together. I'm sure you will get a great dinner tonight, but here in Chile with 4 degrees outside, I will get my my lunch soon. Thank you very much.
Thank you very much, Nelson. So since we are kind of late, I'll probably start the debate with one question for each of our presentations. And for Dr. Hermida, what is from a biological point of view, is it important to understand the type of proteins and the timing of its effect in the different types of cells?
Well, I think it's very important to understand what proteins are released this membrane, because many authors focus on the growth factors, and there are not the only proteins that are there. There are many other ones. So I think it's very important to understand what others are implicated. And well, in my presentation, of course, I say that I found 705, and I don't specify, but many of the proteins that we have that we found at day 3 are implicated in, well, they are released by neutrophils and have bactericidal effects. I haven't tried, but I think that they are also very important in order, when you apply, in order to prevent infections. So of course it's important to know all the proteome, and of course the time over the time, well, the proteins released over the time, it's also important, because when I checked the effects on fibroblasts, if you remember, there were a different effect if applied the secretome collected at day 3 or collected at day 7, that it means there is differences of the proteins released. So I think it's very important to understand how this varies over the time.
Thank you very much.
Welcome.
Marc, there are quite a lot of there is the L-PRF, the A-PRF, the A-PRF plus, the H-PRF. This confuses a lot, especially with also the background of the old PRP. What is actually the difference between the new ones, those new bioproducts?
Thank you for that beautiful question. I can give you a scientific answer and a clinical answer. I will start with the clinical answer. From a clinical point of view, there is no difference between them. They all work in a similar way and with the same benefits. If you go to what is the difference between, the difference is in how the membranes are prepared, being the setting, the time, the speed. The A and the A plus is at the lower speed, with the intention to have a higher concentration of cells in the membranes, but in fact, this has not really been proven. The H-PRF is then in a centrifuge where the centrifugation is in a horizontal situation. It seems to be a little bit beneficial in the amount of cells, but is this clinically relevant? I have major doubts. The T-PRF is in titanium tubes instead of glass tubes. Is this important? We have done one clinical trial comparing the L with the A and the A plus PRF in rich preservation, and at the end of the day, the clinical outcome was the same. of course, better than unassisted healing, but there was no difference between the different products. And also we checked the releasing growth factors between the L, the A, and the A+. And also here we could not find a significant difference. So I think it's more a commercial issue than a scientific and clinical relevant issue. Sorry for the long answer.
No, thank you very much. Wonderful. We talked about rich preservation, Nelson. Which are the most common mistakes for you that you've seen along the line in using the L-PRF for rich preservation?
Well, I think most common is the lack of using a specific protocol all the time, not using the correct amount of L-PRF, because that is quite important. We have seen that it's not the same if you put one membrane, that if you, in that case, you needed 4 or 5 or 6, that can really make the difference on the success of the case. Not using the proper technique of filling. If you are filling, it's not just putting L-PRF inside of a cavity of a socket. It depends on what you try to achieve. You want to recontract the buccal plate or one of the missing plate, you have to put L-PRF in that area in a specific way, and then fill all the rest. And then also seal the socket from on the outside to avoid the migration of the epithelium and to avoid the contraction of the entrance of the socket. And also another mistake is to use the correct suture. If you have an area where you don't have bone, you should not put suture in that area. You should leave that gingiva free. And another common mistake is that people try to get primary closure, and really tight sutures, really try to move all the edges of the soft tissue on the socket, and that is a huge mistake. This has been a technique developed, by nature, to leave all the biomaterial exposed to the oral cavity and not to put tension on the surrounding soft tissue. So I think from my point of view, those are the main mistakes that we can find in risk preservation using L-PRF alone.
Thank you very much. Juan, I'm going to ask you one question that actually I think it was answered by both you and Marc when you talked about the L-PRF block. But I just read a question that came in at after 7:30 with some doubts of the proportion of the L-PRF membranes and biomaterials to prepare that L-PRF block. Can you just just summarize it so it's completely clear to everybody?
Yes, sure. And thank you for the question. Of course, when we started with this technology, was something that we didn't know. And we decided to put one membrane per 0.5 grams of biomaterial. That was what Nelson and Marc told me to do. And then we changed this proportion because without having data, that's clear, we changed this proportion to 2 membranes per 0.5 grams of biomaterial. And the results were very similar. And the advantage is that we are using less biomaterial and more autologous material. So if there is no difference from a clinical point of view, the more autologous biomaterial we can use without, for sure, creating morbidity for the patients, this is the right way.
Okay, thank you very much. And since we are still with the L-PRF block, Marc, how can you explain the fantastic healing of the L-PRF block? Because we've seen just great clinical results. And I feel that it's a technique that can be achieved by a lot of people.
Yeah, I think one of the good aspects is the fact that if you have, for example, a wound dehiscence, you get the nice spontaneous closure. You don't have to do anything. That's, from a clinical point of view, for the clinician, very important. Then about the L-PRF block itself, Ana Castro, one of my PhD students, checked the release of growth factors of these blocks. And also these blocks release growth factors for over a period of 14 days. So also this is a nice aspect. Thirdly, I think that if you think about these chopped pieces of L-PRF in this block, in fact, this is just soft tissue, so it can be easily replaced to become bone. And also we see in the biopsies a very good vascularization, and this vascularization might be explained by the potential growth factors that are released or other molecules. I have to be very careful now, but if you think about 700 different molecules that might be released, and probably over a longer period of time, plus also the antibacterial capacity of the L-PRF membranes inside and also covering. So I don't know which of those is the most important one, but I guess the combination of all is... I can only tell you that beforehand, I was never, before working with the L-PRF bone block, I was never capable of doing this kind of interventions with this nice amount of bone gain. So for me, at least, it might perhaps be because of my bad skills, but for me, at least, it was extremely helpful. Sir.
I think Juan can...
Yes, if you allow me, Mr. Chairman and Marc, I would like to add something, is that when we use biomaterials, we have to wonder what is the objective of using those biomaterials. Is to keep the space, or is to induce bone regeneration? Probably is to maintain the space. The problem is that, for example, if you go for a sinus lift without L-PRF, or for a horizontal bone augmentation with L-PRF, like, because I'm Galician, I'm going to ask you something. How much material or biomaterial do you need to use without the L-PRF for a sinus lift? Do you need to pack everything or to leave holes, like he was saying? Because there is something important and critical here, is to understand the bone biology, the metabolism of the bone. Because bone is a tissue that grows by itself. The only thing that it needs is to need the space and the right conditions to do it. And this is the way how the fractures of the different bones heal. So in the mouth is exactly the same. So we need biomaterial. We don't know how much biomaterial we need to maintain the space. But at the end, the important issue is the proper bone that you have afterwards. There. And if you have something that can induce, a bone regeneration such as the L-PRF, this is going to be better, clearly.
Okay, Marc.
And I just got to add, something is that we have checked the composition of an L-PRF bone block, and we saw that at the end of the day, in this block, the amount of bone substitute is only 36%. So more than 60% is blood of the patient.
Thank you very much. Juan, on the soft tissue management, how many L-PRFs do you generally use to use for root coverage? Because you showed some cases that were very good, but when you want to use You just said that if you don't need too much, if you have enough keratinized tissue, you can go for a L-PRF only procedure. In those cases, how many membranes will you use?
Yeah, a clear thing is that this is the decision-making for root coverage. If you have, in baseline, if you have enough keratinized tissue, let's say in thickness and height, you don't need probably connective tissue graft. You can go for a coronally advanced flap by itself. But in those cases where you have, again, keratinized tissue, if you add L-PRF membranes, the success is better according to literature. Okay. The problem is when you don't have connective tissue or, keratinized tissue, then you have to produce the keratinized tissue. And the keratinized tissue is produced, or the keratinization of the epithelium is produced by the superficial layer of the keratinized tissue coming from the palatal mucosa. And it has to be the connective tissue that is really underneath the epithelium, because the fibroblasts that are active are in that zone. If you take the fibroblasts that are in the other side, in the bottom side, you are not going to obtain keratinized tissue. So in terms of how many layers do I use, usually I use 2, but please don't ask me why. Okay. I don't have data so far. I promise for next meeting to have something.
Okay, thank you very much. But I mean, with so much material that you all showed, we could stay here all night long. But so the last question goes to the other side of the Atlantic. Nelson, can actually L-PRF modify the osseointegration process? And you showed us some cases that go in that line, I suppose.
Yeah, I think we should be very careful about, what we say about that. But I think there is enough scientific and clinical evidence to say that L-PRF helps on the osseointegration process. How really it modify the process, and we still really don't know, don't have many answers about that. But the study that we are running, and I think all the study that, all the knowledge that will contribute, Lidia maybe in the future, and all the people that are doing really basic science on this, maybe will clarify how really L-PRF will modify the osseointegration. We already know, as many of the speakers already said, what we do today is good. We have been doing implant for more than 30 years, and they work without L-PRF. Now, if we add L-PRF, maybe there is a benefit, and I think we should go in that way. Why not to use it if we can see clear benefit? I have shown you cases that should be impossible to do it, and that is impossible to do it under traditional way or regular technique that have been proved for many, many years. Now we want to challenge that, of course, under the scientific view. Okay, there is an open space that we need to fill with a lot of answers, but I think at this point, there is no reason for not to use this beautiful biomaterial that nature gave us and try to get the most benefit, as everybody said, for our patients. I think that should be the focus of our treatment. And if we can improve the success, even maybe in the long term, improving the success of implant, especially with the pandemic of perimplantitis that we are seeing today, why not to use it in our implant? So my answer will be yes, we can modify, we can get better osseointegration, we can speed up the osseointegration by using L-PRF around the implants.
Thank you very much, Nelson. I must say that kind of a secret, I had extremely high expectations for this meeting today? Well, thanks to the brilliancy of these 4 speakers, those expectancies were really surpassed. And I just have to thank you for all the knowledge you were able to give to us today. And to finish, to thank again the SEPA Foundation and the BioHorizons Camlog for the invitation. And I just hope that all around the world that listen to these 4 brilliant speakers, I hope you had your share of knowledge, and like me, you also learned a few things today. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, everyone.